Oke, udah jam 17.11. Akhir izin dokumentasi yang teman-teman semuanya. Mungkin yang pertama itu ada gaya formal terlebih dahulu. Aku hitung, satu, dua, tiga. Selanjutnya ada next slide. Satu, dua, tiga. Selanjutnya gaya story teman-teman. Oke, untuk slide pertama. Satu, dua, tiga. Untuk slide kedua. Satu, dua, tiga. Oke, terima kasih teman-teman semuanya.
Baik, selanjutnya untuk para peserta bisa melakukan pretest terlebih dahulu. Eh, untuk link pretestnya mungkin bisa di-share oleh Fikri. Terima kasih. Untuk pretestnya ditunggu sampai 17.15. Baik, karena sudah menunjukkan waktu pukul 17.15, mungkin kita sudahi dulu untuk sesi pretestnya. Selanjutnya, kita akan mendengarkan materi pertama dari Dr. Gilbert. Mungkin untuk Dr. Gilbert, apakah sudah hadir di Zoom? Selamat sore, Dok. Gimana, Dok, kabarnya di sore hari ini?
Oh ya, baik, baik. Ha.
Oke, baik. Saya izin untuk membacakan CV terlebih dahulu. Dr. Gilbert merupakan anggota dari OUCRU atau Oxford University Clinical Research Unit di Fakultas Kedokteran Universitas Indonesia. Sudah lulus dari Fakultas Indonesia FKUI tahun 2021 hingga 2023. Dilanjutkan dengan Bachelor of Medical Science di FKUI juga tahun 2017 sampai 2021. Untuk license dan certifications-nya ada Advanced Trauma Life Support, Advanced Cardiac Life Support di Konsorsium Trauma Indonesia, Indonesian College of Cardiology, dan juga sebagai Cochrane Member, Associate Member dari World Medical Association, Student Member dari American College of Physicians, Student Member of European Society for Medical Oncology, dan lain sebagainya. Jadi dari CV-nya udah terlihat ya teman-teman semua kalau Dr. Gilbert ini pengalamannya sudah banyak banget di bidang research. Jadi mungkin setelah ini teman-teman semua bisa mendengarkan materinya dengan baik karena pasti akan sangat bermanfaat buat teman-teman semua. Oke, baik Dok, boleh untuk dimulai materinya. Terima kasih.
Oke, terima kasih kesempatannya. Sore semuanya, perkenalkan saya Dr. Gilbert yang akan membawakan sedikit sharing-sharing materi tentang tentang gimana cara kita untuk bisa meningkatkan kualitas dan produktivitas research terutama di konteks Indonesia. Sebelumnya ini untuk sesi presentasinya dalam bahasa Inggris atau bahasa Indonesia ya? Atau bebas
Untuk
saja?
dokter bisa menggunakan dalam bahasa Inggris, dokter.
Kenapa? Gimana?
Izin bisa dalam menggunakan bahasa Inggris, dokter.
Oh, oke, oke, oke. Oke, kalau gitu saya izin share screen dulu ya. Boleh tolong di approve request untuk share screen-nya? Okay, so good evening, everyone. Thank you very much for the opportunity. My name is Gilbert, and I am a medical doctor by training from the Faculty of Medicine Universitas Indonesia. Currently, I am also working as a researcher at the OUCRU Indonesia since 2021. I work primarily as a research assistant, but in some projects, I also work as a project coordinator and also as a data analyst. And up until now, I have been working on three main areas of work. First is COVID-19. In the first project here, we aim to investigate how the COVID-19 variants impact the patient outcomes like severity and mortality and how does vaccination affects those patient outcomes. And in the second project here, which is called INVITE, or Indonesia Vaccine Immunity and Infection Evaluation, we try to evaluate how COVID-19 immunity wanes over time and what is the impact of vaccination and breakthrough infections on the immunity of the patients. And recently, I have also been invited to work on HIV projects. And here we have published the baseline characteristics. And we are trying to develop a system to better detect acute HIV infection in Indonesia, primarily in Jakarta and Bali. And currently, we are also working to develop a risk score to detect acute HIV infection to prevent further spread of the infection. My main areas of work will be antimicrobial use, or AMU, and antimicrobial resistance, or AMR, both of which I work as a data analyst. And here we try to investigate the state of antimicrobial use and antimicrobial resistance in Indonesia throughout the previous years. And these two are systematic reviews that we will do a case study on after this. I believe I have shared the PDFs of the journal articles. So if you have received those, please take a look at that. We will try to discuss the papers further deeper. And recently, we are also invited to collaborate with the WHO. And the project is divided into two parts. The first part is to do a scoping review to scope the global knowledge gaps on AMR in the human health sector. And this has been translated to the global research agenda that is published by the WHO last year. And the second part here is the currently ongoing, where we are invited to do a systematic review on the status of AMR globally. So that's a brief introduction about me. Now we go into the topic. So why do we need to do research? William Osler, one of the founders of the Johns Hopkins University, once said, "He who studies medicine with books sells an unjust disease, but he who studies medicine without patients does not go to sea at all." If we take a look at the past, most, if not all, of the medical knowledge and medical practices that we learn and we practice now is based on evidence. Where does this evidence come from? Of course, it comes from research, from publications, from practical observations, etc. So we see that research is a fundamental to the development of modern medical practices and modern medical knowledge. How about research in Indonesia? We see here that research, especially in the medical field, has been booming in Indonesia since the past decade. In 2015, here, Indonesia is the green line here. We are still trailing behind other countries in Southeast Asia, including Malaysia, the blue line, Thailand, the purple line here, and Singapore, the orange line. Recently, since 2023, we have surpassed all of this country and become the most research productive country in Southeast Asia, especially in the field of medicine. However, this does not come without a problem. We are shocked to see news on the fact that senior authors claim a credit on a paper that he or she didn't work on, while a junior researcher who did all the work didn't get any of the credit. So this is called a ghost authorship. And we are quite shocked to see that the news mentioned that this is pretty common in Indonesia and is common academic misconduct in Indonesia as well. What is also concerning here is that in the right panel here, we see that also in terms of the number of articles, we have surpassed all other countries in Southeast Asia. We see here that the number of citations per article, we are still trailing behind other countries. Like we see here for Indonesia, we only have like around 10 to 20 citations per article. But for other countries, for example, Singapore, they have almost 300 citations per article. So this means that most of the research in Indonesia still focus on the quantity of the article rather than the quality of the research. So why does this happen? To better understand the cause of this, we have to understand how the performance of researchers in Indonesia are evaluated. The government uses a Sinta score system to evaluate the performance of researchers in Indonesia. And basically, the system consists of number of publications and number of citations. And the scores are stratified according to the quality of the journal. And what is quite concerning here is that we see that one publication in a Scopus non-Q index journal is equivalent to 30 Sinta score. However, one Scopus citation is only equivalent to 4 Sinta score. So this means that one publication in a non-Scopus index journal is equivalent to 8 Scopus citations, and this further drives researchers to publish as many as they could without prioritizing the quality of the research. Based on my observation and also doing some review on reading some on the articles, internet articles, I found that there are some common academic misconduct in Indonesia. First is salami publication. We can illustrate one big research as a whole cake, but in a salami publication, they divided the cakes into tiny parts and publishes them to the different journals. So this might not seem like problematic initially, but if we take a look further, this causes readers to not be able to understand what is the meaning of the articles, what are the intent of the research, and because the articles contain very little information on the whole picture, it has little impact on the community. And the second is data dredging without hypothesis, in which we collect data. The researcher collects data without any underlying knowledge or underlying hypothesis. And well, after they collect the data, they often get lost on how to analyze, on how to connect their analysis interpretations. So it is commonly not encouraged to do that. So before we start the research, we have to have an underlying hypothesis, underlying research that we want to evaluate first. And the third one here, I believe you are all familiar with this one. This is predatory journal publishing, where a researcher focuses on publishing the article as fast as he or she could, even if it means sacrificing the quality of the or the academic integrity of the article. So in a predatory journal, we publish an article and pay a lump sum of money in return for a. And the fourth one is actually not an academic misconduct, but is a common observation in Indonesia where in researchers in Indonesia and also in some parts of the world have poor report keeping and data management, so that many of the important variables are missed, and even if we collect the information, some of the information are missing, so incomplete. There's incomplete data, so it precludes our ability to do a solid analysis, a robust interpretation of our findings, and that further limits the quality of the research in Indonesia. And the last one is ghost authorship, which I have mentioned in the previous slide, where a junior researcher cannot climb his or her research career because he or she did all the work, but the senior researcher claims all the credit. So we can conclude that research in Indonesia and in many parts of the world is still often driven by metrics and rankings rather than community needs. So how do we improve the quality and productivity of research in Indonesia? Here I mentioned 7 steps of key guides to successful research, and we will discuss these steps one by one in detail after this. But before that, we're going to take a look at these 2 articles. So the left one here is the systematic review on antimicrobial use in Indonesia, and the middle one here is the systematic review on the AMR status in Indonesia. So we will take a look at these 2 articles as a case study, and then further see how these 2 articles connect to the recent WHO publication. So yeah, to be able to do a research that is meaningful for the community, we have to identify the problem in the community first. We see here that the UN General Assembly in 2024 commits to reduce AMR-associated death by 10% by 2030. So relative to 2019, this means that Indonesia has to reduce AMR deaths by 55,000 in 2030, so by 7 years. And that means we have to reduce around 8,000 number of deaths per year. And we see here that the number of deaths caused by AMR is still pretty high, around 182,000 cases only in 2024. So we see the magnitude of the problem of AMR in Indonesia, and to effectively reduce the number of deaths caused by AMR, it is important for us to understand which pathogens contribute most to the AMR disease burden in Indonesia. So the Indonesian Society for Clinical Microbiology, or in Indonesia we know as PAMKI, regularly publishes annual reports on the status of AMR across Indonesian hospitals. The number of participating hospitals has increased quite rapidly, from only about 40 to 50 in 2022 to 75 hospitals in 2023. So it increased nearly 50%. However, there is one limitation to this report. Although this report, we can argue that this is one of the most comprehensive report done in Indonesia. There are limited AMR data from the community settings because all of the isolates come from hospitals. So based on this problem, we want to further quantify the problem of AMR in the community settings, in addition to the hospital ones. So to do that, we conducted a local initiative to summarize the peer-reviewed literature on AMR and antimicrobial use in Indonesia. And here we did 2 separate systematic reviews, one on the antibiotic consumption in Indonesia and a second on the AMR status of Indonesia. So these are actually 2 different projects conducted by 2 different teams, but since they are tightly related to each other, we often deem these 2 reviews to be a counterpart of each other. After we define the research focus, then comes next is to develop a rigorous methodology. There are 5 steps to do this, and we will discuss one by one. The first is to define a research framework, and a common framework that we can use is PICO. P stands for population, I for intervention, C for comparison, and O for outcome. This can be applied also, other than systematic review, could be also applied to primary research, and could also be adjusted according to our study type. For example, as our systematic reviews is a systematic review of prevalence, then we do not have any intervention or comparison, so we can cross this out. The population is spectral AST on isolates from human specimens collected in Indonesia from the past 24 years. and the outcome is the prevalence of AMR. This framework could be further adjusted. For example, if we do a systematic research on diagnostics tests, then we could change the intervention to index test and the comparison to reference test or the gold standard tests. For prognostics, it is important to also mention or define the settings. For example, is it in hospital or pre-hospital or community settings, and also the timing, whether we want to evaluate the prognostic effect in 28 days, 1 month, or 1 year, etc. After we define the research framework, we should decide on the feasible research scope and methodology. And here the design is systematic review. The population is isolated, collected from patients, regardless of their clinical context. The period limit is 24 years. So from 2000 until 2023. Geographic setting is limited to Indonesia. And here I added a fifth component, which is also important, but may not be applicable in all of research. So in many research, we have to collaborate with funders or other institutions because of the scope of the work, because of the cost that needs to be covered by these funders, etc. But since our systematic reviews were a local initiative and it doesn't require much effort on funding and the screening, so we didn't have any funders and we didn't have any other institutions for collaborations. So after we decide on the methodology, we have to refine this methodology before we do the actual research. In refining this methodology, I will highlight the roles of three roles here. First is a clinical expert, and in our case, it is an AMR expert who also acts as a principal investigator in our research. So the clinical expert helps us to refine the novelty, impact, and relevance of the research. And the PI also acts to guide and oversee the conduct of the study. And as he has many experience in previous similar research, he ensures that all of the relevant information is collected so that we can have relevant and reliable information for the analysis, and that we have such granularity of the analysis so that we can we can have many conclusions and many interpretations that we can use to inform findings to local stakeholders. And the second here is statistical expert. The statistical expert helps us to strengthen the robustness and comprehensiveness of the plan analysis and to ensure that the analysis plan will yield valid and meaningful results. In the case of systematic reviews, a statistical expert could take in form of a librarian, which helps us to refine the search strategy, the search keywords to help us identify all of the relevant literature. And the statistical expert also help us in deciding which analysis to take. For example, do we want to use a weighted mean prevalence or a meta-analysis? And if we opt to a meta-analysis, whether we want to take a fixed effect model, or random effect analysis, or frequencies, Bayesian, etc. For primary research, a statistical expert could also help us in identifying data structures that we are not familiar with. For example, if we collect data from many hospitals that may have different patient characteristics and different treatment characteristics, then we have to employ multi-level modeling. If we conduct just a simple retrospective study to develop an association model, then we could just do a simple logistic regression, etc. So statistical expert helps us to identify our data structure and to decide which analysis is best suited for our data. And lastly, we should also consult with stakeholders, either in the local level or regional or even in global level. So these stakeholders could help us identify their needs and align with the health policy priorities. And this is most applicable in terms of AMR because we see AMR as a rising global concern in recent years, especially since the introduction of the COVID pandemic, because the pandemic causes people to use antibiotics recklessly, so the prevalence of AMR and that's caused by AMR has risen rapidly in recent years. With stakeholders, we should also discuss strategies for translating our findings into practice. So how they can use our findings, our research is also important for us as well. But this is more applicable after we have the findings of our research. So after we consult and refine our methodology, then comes piloting the research workflow and data extraction form. Here, I would also like to highlight 3 roles. First is the investigator, including us, because as a researcher, we are also investigator and also the principal investigator. So the PI or the principal investigator advise on the most effective way to collect data and ensure that all relevant information is collected before we do the actual data collection. And the data manager verifies the clarity and the usability of data extraction form, and to ensure that a consistent and standardized approach to data collection, including appropriate data coding. So these 2 are pretty important because it is when we are handling big data sets, it's very hard if we use if the entries are not standardized. So in collecting data, we should minimize the use of free text. For example, like if we want to collect data on gender, for example, we could just code like, for example, male or female. Male, maybe we can number as option number 1, and then female option number 2. This is much simpler than if we leave the blank open and then people can say male, female, boys, girls, and even with the different typographical writings, different caps lock, etc., that will complicate our analysis. So in extracting data, we should always use a consistent and standardized approach and minimize the use of free text. And lastly, we should also do a literature review on previously published research, because those previously published research could help us identify the key variables and to inform the design of the data extraction form, because they've been there, they've done the research before, so they can inspire us on how to design our extraction form, what variables to collect and what not to, etc. And we should also find relevant guidelines to guide our research conduct. And for AMR here, for example, we have WHO. So the WHO has a subsidiary called GLASS, and GLASS publishes a manual on AMR. So we could follow the guideline and decide on the important bacterial pathogens that we should include in our review. After we pilot the research workflow and the data extraction form, then before collecting data, we should stop, think, and act. We should think and ensure that all relevant information is captured, because when we start the data collection and then halfway through we realize that there is some informations or important variables missing, and then we go back to the whole process again and we start collecting data again, then we will be stuck in a vicious loop of data collection, and this will complicate our research. This will take a very long time in collecting data, etc. So that is not an ideal and an effective way of collecting data. And the second is we should use a consistent approach in collecting data. We should verify that the data extraction form is complete and ready to use, and we have piloted those data extraction form using common data collection softwares. So there are some common data extraction platforms. First is RedCap, which is commonly used for primary research. The second is Confidence, which is primarily used for systematic reviews. And the third one is Microsoft Excel or Google Spreadsheet, which is quite versatile and can be used for any type of research. So why did I emphasize on ensuring that all information is captured and to use a consistent approach in collecting data? This is because, from my observation, 2 of the most common pitfalls in Indonesian research are incomplete or missing data that didn't allow us to makes our analysis more complex, because we have to account for the missing data and we have to do an imputation, and also reduces the power of our analysis. And the second is the lack of important covariates. So we collect the independent and the dependent variables, but we didn't account for the confoundings and other variables that may affect the observation between independent and dependent variables. So these two components, incomplete data and lack of important covariates, are 2 things that we should minimize as much as possible in research. And after all is said, we should execute the protocol, and whenever we can, we should avoid deviating from the protocol. After we finish the data collection, then we should interpret our findings or data. We should process our data so that people can digest it. When we analyze data, I always try to start with the descriptive first. For the systematic review on antimicrobial use, we had 9,000 search hits, and we included 107 reports comprising of more than 5 million patients. For the AMR systematic review, we had 2,000 search hits. We included 102 reports, and we analyzed almost 20,000 isolates. Also, the number of isolates for the AMR systematic review is quite small compared to the antimicrobial use systematic review, AMU systematic review. This represents one of the biggest effort in illustrating or drawing a big picture on the MSLs in Indonesia. So this still has novelty in it. And then we collected data throughout Indonesia, although mostly in Java, but also in some parts, other parts in Indonesia, like Sumatra, Borneo, Sulawesi, and also in Papua as well. And this further illustrates the large scale of our research. And here I would like to encourage you all to focus on creating one piece of research that makes a real impact instead of many small research that makes a little difference. So whenever we do research, our ultimate goal is to help others, is to help the community. So we have to start from the community needs. We have to identify the problems in the community, and then we should focus on the quality of the research rather than the quantity of the articles. So after we finish analyzing the descriptives, then we should do the main analysis and interpret the findings. We are not going to look into details on the results, but the main point that I want to deliver here is for us to find an effective way to visualize our main findings clearly and concisely. This is to help readers and audience to better understand what is our research about, what we want to analyze, what we analyze here, and what is the main key messages from our research. And for those visualizations, you could take a look for inspirations in previously published study, because they typically have a similar data structure than our research. And we could also take a look at websites. And here I highlighted data2Vis because I use that as well. So data2Vis helps us to identify which variables we want to visualize, and also what kind of visualizations are ideal for our type of research, or for our type of data. And the third one is conference and symposia, because in conferences, people try to present their findings concisely and using as many visuals as they could. So typically, beautiful figures, we can find beautiful figures in their presentation, and we can use that as well. Okay, so here are the main findings of our reviews. For the systematic review of antimicrobial use, we found that on average in hospitals, there is an average 1.3 daily doses of antibiotics per hospitalized patients per day. Meanwhile, in community, about 12% of the population consumes 1 standard daily dose of antibiotics per day. So this shows that the rate of antibiotic consumption in Indonesia, both in the hospitals and the community, is still very high. However, in terms of prescribing appropriateness, less than 50% of the antibiotics used are prescribed appropriately. 34% in the hospital, and 49.4% in the community. So this shows that this is pretty concerning, because most of the antibiotics used, like 1 in 2 antibiotics consumed, are not indicated. We found a favorable association between antibiotic consumption, prescribing appropriateness, and guideline compliance with improved patient outcomes, which is in terms of prevalence of AMR and deaths caused by AMR. However, we also found that there is a poor antibiotic knowledge in the community and frequent self-medication of antibiotics. In the AMR review, we found that in hospitals, carbapenem resistance is a rising problem in gram-negative bacterial infections, with Acinetobacter being most of the prominent problem. Like we found here that about 71% of the Acinetobacter isolates exhibits resistance to carbapenems. And there is an increasing trend of carbapenems and colicin resistance across gram-negative bacteria, and this includes Acinetobacter, Pseudomonas, E. coli, and Klebsiella. In the community, carbapenem resistance is also a problem in the E. coli and Klebsiella, because most of the Acinetobacter and Pseudomonas infections are occurred in hospitals. And however, we found that AMR prevalence was generally lower in the community rather than in the hospitals, which are quite expected. However, there are limited data from the community, so there's still insufficient evidence to draw robust conclusions on the full AMR picture in Indonesia, especially in the community settings. So after we analyze and interpret our data, what do we do next? Of course, we publish our research and we inform our findings to local stakeholders. So we inform our findings to the Indonesian Society for Clinical Microbiologists, or PAMCI, in which they responded by publishing another regular annual report, and they compared their estimates with ours. And one of the professors and one of the directors from the PAMCI also in her inaugural speech mentions how we could tackle AMR from the One Health perspective using data from our research. We also collaborated with the Indonesian FDA, the Ministry of Health, on how to tackle AMR, on how to increase the awareness of Indonesian population in reducing the rate of AMR, etc. And we also collaborated with the WHO of Indonesia to translate our findings into recommendations and into policies that can be used for the National Action Plan of AMR in Indonesia. We didn't stop there. We also inform our findings to the global stakeholder, in this case WHO, and really excited with our things, and they see this as a prospective project. So they invited us to collaborate on a global scale project. So basically similar research, similar systematic review, but within a global scale. So this resulted in another big project in which we are collaborating with the WHO and University of Calgary to investigate the status of the AMR rates in common bacterial pathogens in globally, so in all countries. So in doing this, we consulted with the WHO because they have been quite focused on AMR. So if we see like publications on AMR from the WHO and also from other journals has increased rapidly in recent years. And the Lancet has also taken a standpoint in which they deem that AMR is a global health emergency and should be taken care of seriously. And the WHO also has published a global research priority for AMR in human health recently, and this is based on our scoping review and is also a momentum to our research and publications as well. So what do we do next? We repeat the whole steps again. After we agreed on a global scale project, we defined the research framework, which is still a systematic review, but now we limited our population only to people seeking care at healthcare facilities with confirmed clinical infectious syndromes. And for feasibility, we limited the periods to only the last 15 years because it will take quite a lot of effort to scope all of the last 25 years. And the geographic settings is limited to global scale, so all of the countries. And we collaborated with the WHO as the funder and University of Calgary as other institutions in collaboration. So in brief, we investigated the status of AMR in 5 syndromes. First is bloodstream infection or sepsis. Second is urine. Third is stool. 4 is lower respiratory specimens or sputum for respiratory infection. And the last one is meningitis or from CSF. From these 5 syndromes, we screened around 35,000 records, and we included 4,000 of which and analyzed approximately more than 2.5 million isolates. So we can see the scale of the project, how big it is, and that's why this project has been running for almost 3 years now. Okay, so that concludes our case study. What are the takeaways, and how can we optimize research quality and productivity in Indonesia? First is to dream big and start small. Rather on focusing on the quantity of the research, we should focus on creating one piece of research that makes a real impact to the community instead of many small research that make little difference. We should also collaborate with others, other institutions and other peers, which we also consult and discuss with clinical and statistical experts and the relevant stakeholders to ensure the novelty, feasibility, and the relevance of our research. Before collecting data, we should stop, think, and act and to ensure everything is in place and ready to go before we do the data collection to prevent us from being stuck in a vicious loop of data collection. Lastly, in addition to publishing our research, we should also connect our research with others, disseminate our research using social media, news, and inform our findings to local and international stakeholders. So I would like to encourage you all to think big, dream big, believe big, and in doing so, we have to consistently take small steps to achieve a big results. And one thing that I would also mention is that research is not a one-man show, and whenever we need to innovate, we need to collaborate with others because in research there is no one-man show. I think that's all that I can say. Thank you very much for the attention. I will give the time and place back to the moderator. Thank you.
Okay, thank you very much for Dr. Gilbert for the very beneficial and interesting materials. Maybe after this, can we do question and answer, Doc? Or is there any other session that you want, Doc, want to do for now? Or
No,
can
it's okay.
we go? Okay.
Yeah.
Okay, we can move to the question and answer session. Maybe for all of the participants, buat partisipan semuanya, kakak-kakak dan teman-teman, if you have any questions, you can raise your hand. For Kak Ibrahim.
Hi, okay. I hope my voice is audible. Before that, I want to say thank you so much to Dr. Gilbert for the presentation about how we can conduct a robust and a good research productivity. I actually have a few simple questions regarding the piloting research workflow and data extraction form in the Stop, Think, and Act, because this is something that I've encountered a lot in my systematic reviews and meta-analysis. Is there any like specific steps or maybe specific things that you need to kind of like look to verify the data extraction form for your systematic review and meta-analysis? I know that sometimes likewise what Doctor said before is that we can look up previous literature reviews or systematic reviews and see how they do their data extraction, right? But sometimes if we have a different research and maybe there's a different outcomes that we want to extract from the data, we kind of have to like rethink about what should we verify for the data extraction form, and maybe is there like any tips or any specific things that we have to look out for verifying this data extraction form? I think that's the first question. Thank you so much, Doc.
Okay. Thank you for the question, Ibrahim. So, sadly, there is no holy grail in extracting data. So there's no one answer that could one template that could fit all questions or research questions or research types. But there is some common information that we could extract. For example, like the author, year, study design, the population, and this also differs by systematic review types. For example, if the systematic review is we identify that diabetes or hypertension is an important comorbidity, then we should extract this as well. But the principle is that whenever we are in doubt, we should extract as much as possible, even if it means that we have to take a look at the at each of the paper for longer, because it prevents us from having to go back to the articles again in the future. So to improve our data extraction form, of course, we need to take a look at previous systematic reviews or previous research as much as we could, and try to see what informations, what variables we can also extract to improve the clarity of our data. But it also comes with experience and also with observation as well. So when we have done many research, then we will get used to it and also can identify which variables are important for us to extract as well.
Okay, so I'm assuming that maybe we should, I guess, refer back to previous systematic reviews or meta-analysis, and then if we are unsure of which data to extract, I guess we can extract like most of them, and just in case we don't have to come back to those papers again to extract any necessary data. And I think I guess it's also okay to consult to maybe a statistical analysis or expert about what kind of data or maybe what kind of relevant things that we should extract. I have one final question also. Whenever I was doing my systematic review or meta-analysis, and I do sometimes face the common pitfalls of Indonesian research, such as missing data or maybe lack of important covariates, or maybe the data that are presented in the research paper is somewhat quite difficult to, I guess, kind of like put it for the systematic review or like the meta-analysis. And if in that cases, if the data are missing or the data are like inconvertible, is it better to still extract some of the data that is, I guess, necessary for the paper, or just leave the whole paper because it's counted as incomplete?
Okay, it depends on our eligibility criteria, but for systematic reviews, typically like conference proceedings, because it is not eligible in our in systematic reviews because it typically only has an abstract and we cannot fully judge the risk of bias from that study. But well, in some cases, for example, if we use Robbins I from to judge the risk of bias of non-randomized studies, if we choose the risk of bias to be critical, then it is justifiable for us to exclude the paper from the systematic review. But otherwise, in most cases, we do not exclude studies based on risk of bias and based on data completeness, as long as the data has the information or the outcomes that we need to analyze.
Okay. I think that's all for me. Thank you so much, Doc.
Thank you.
Okay, so I hope the question has been answered for you, Kak Ibrahim. For the next question is from Kak Laurentia Videla. Halo, Kak.
Yes, hello. Good night, sorry. Good night, Dr. Gilbert and everyone. Thank you for your presentation. It made me reflect on how we should do research, not focusing on the numbers, but focusing on the key question itself and the impact to our medicine field. So what I would like to ask you is about how to visualize systematic review with heterogeneous data. For example, I once did a research on a systematic review on regenerative therapy for psoriasis, but not many human studies are available. So we ended up have to include case report and then phase 2 clinical trial and 1 RCT. So in that case, we know that it's definitely heterogeneous. How to visualize them to make them more interesting for the audience. As far as I know, the table can be used for us to visualize, but sometimes when you are reading an article, table is like a bit boring, like it's all a written part. So how do you suggest for us to create some graph or something like that? Thank you.
Okay, thank you. Yeah, I agree with your point that although table holds a massive amount of information, it is in many cases it is not visually appealing and it is hard for the readers to understand the main messages from the tables. Cochrane actually agrees on justifying not using meta-analysis when there are substantial heterogeneity, especially when there are different study designs, and they actually suggest some ways to visualize and or do the analysis when we don't do a meta-analysis. So if you search further from the Cochrane guideline, you can find vote counting, so effect direction based vote counting, and it is the recommended practice of analyzing the data whenever from a systematic review whenever we don't do a meta-analysis. And here I could share one slide on what visualization that we can use whenever we don't do meta-analysis. And well, if we take a look, meta-analysis is of course accompanied by a first plot. But if we only do a systematic review, then for example, if all of the reports reported, all of the articles reported data on odds ratio or relative risk or an effect estimate that we can commonly use, then we can visualize it using bubble plot here. But if we only find p-values for all, if we only find the p-values, then we can use arbitrary plot here with 1 dots representing 1 p-values. This is the one one-way p-value, so not two-way p-value, not the asymptotic p-values that we typically get. And another alternative to this bubble plot is box and whisker plot. So the data type is actually same. And the last one, and I think this is most applicable to your case, where there are different interventions, different outcomes, is that we can use harvest plot here. So basically, we counted how many of the like this figure from 1, 5, around 10. Yeah, from the source studies, we identified that 2 favors other models and 10 favors with bioflag models, and we can further stratify this based on risk of bias, based on population, etc. So yeah, I think this can be used, like harvest plot can be used for most systematic reviews using effect direction based vote counting. I think that's it. I hope this answer. I try to fetch the link to the concurrent guideline.
Okay, thank you, Doctor. Can you suggest us on the application or website that we can use to generate those graph?
For the harvest plots, I think Excel can do the task. Bubble plots, box plots, etc. I think Excel can do the job. For albatross plot, I'm not so sure. I have done it using R, but I haven't done it using other softwares. But in most cases, I think Excel will be sufficient.
All right, thank you so much, Doctor. And one more question from me. Can you also share in brief on how did you get a position in the OUCRU? I went through the link that you gave us at the end of your slide, and there was an information on the careers at OUCRU. Do we just apply to that link or how? Because when I see through it in brief, they require such advanced experience, especially for us in recently graduated medical doctors. It may not be possible. Thank you.
Thank you. Yeah, so it's actually a unique journey. I actually joined OUCRU when I was still in medical school. So well, I actually did some individual projects during my medical school, and then I reached out to one of OUCRU professors because I want his guidance on and his perspective on HIV because he's an HIV expert. And then from that project, we went on to another project and we published several papers, and we found that we can work together really well. So he invited me to work with OUCRU and become more involved in OUCRU projects. So, but answering your question, I think many of the research assistants in OUCRU is actually fresh graduates. So feel free to apply whenever there are job openings, and well, I think OUCRU will be open to junior researchers that are trying to thrive in research and to improve the research in Indonesia.
All right, thank you so much, Doctor, for sharing your experience and knowledge.
Okay, thank you for the question and also for the answer from Dr. Gilbert. Doctor, there is a question from the chat. I will read it. Excuse me, doctor. I would like to ask for tips on how to connect to stakeholders or organizations to maintain research relevancy with health policies and clinical practice, because we are still students and not professionals yet. Thank you very much.
Okay, thank you. So in that case, I will answer from the perspective of students. So because we are still under one institution, our medical school, then I think first we should reach out to our medical school. For example, when I was in medical school, we did a project to evaluate the willingness to volunteer of medical students in Indonesia to volunteer in the pandemic. And under FKUI, we bring those results to the Ministry of Health and Ministry of Education. So we organized a webinar with media press there, including the institution from UNER and FKUI, and also we have representatives from the Ministry of Health and Ministry of Ministry of Education. And after that, there comes a guideline where a massive online open course that helps students to understand the risk and how to better help in volunteering in the pandemic. And it also helps the government to understand how we can help and in what role we should help them. So yeah, if we are still under medical school and we are still students, I think the best way to do that is to reach out in the university level first, and then I believe our doctors or professors could leverage up our research to other stakeholders.
Okay, for Kak Arkan, does it answer your question, or do you want to ask another follow-up question? Okay. Okay, maybe is there any other question from the other participants? You can raise your hand. Okay, maybe for the question and answer session, we can end it. And now we will move to the next session, which will be the certificate and documentation for Dr. Gilbert. And while we do the documentation for the participants, we can do the post test. Mungkin untuk Fikri boleh di-share untuk post testnya, link post test. Terima kasih. Mungkin untuk Fikri boleh dipandu untuk dokumentasinya. Terima kasih.
Okay, thank you, Ina. So now we can take documentation, doctor. Maybe for the first station, maybe we can formal. Okay, I can capture 1, 2, 3. Okay, the second maybe can like post Corey, doctor. Okay, let's see, please. Okay, thank you. Okay, I will capture 1, 2, 3. Okay, documentation is done. That's enough.
Okay, now for the documentation has finished, and for the post test, we can still wait until 18:15. But for Dr. Gilbert, if you have other things to do, maybe we can end the presentation and the session for Dr. Gilbert here. Thank you so much, Doc, for the very interesting topics. It's also really new for me, but it's very interesting and very beneficial. And I hope it's also beneficial for the other participants too. Thank you so much. You may leave the Zoom now if you have other things, Doc. Thank you.
Okay. Thank you very much, everyone, for the opportunity. It's very exciting to share my experience and also my knowledge to others. I hope that what we learned today will be insightful and also beneficial for our further research career. And I hope to meet you all in future collaborations. Bye bye, everyone. Thank you.
Thank you, Doc. Also for the other participants, if you have finished the post test, mungkin Fikri setelah ini isoma terlebih dahulu ya.
Oke,
Oh,
thank you, Ina. Oke, jadi kepada seluruh partisipan yang sudah hadir pada Zoom sore hari ini, mungkin kita akan melanjutkan kembali untuk training basic workshop kita di pukul 19.00. Mungkin kepada teman-teman bisa sudah muncul atau join di Zoom saat jam 18.50. Terima kasih teman-teman semuanya.
Untuk teman-teman dan peserta boleh leave terlebih dahulu dan masuk Zoom lagi pukul 18.50 karena akan dimulai pukul 7 lagi ya untuk materi keduanya. Terima kasih.
Oke, next slide, karena kita udah pretestnya juga. Nah, kita bakal bahas tentang data ekstraksi data itu apa. Next slide. Nah, jadi kalau misalnya kita bahas tentang data ekstraksi atau ekstraksi data, itu proses di mana kita tuh mengambil ataupun kita mencatat sebuah data yang udah relevan yang berasal dari sumber-sumber tertentu. Misal kita ambil yang dari primary research, berarti datanya itu data mentah, ataupun dari secondary research yang datanya itu biasanya udah diseleksi. Biasanya kalau misalnya mau publish kan kalian harus seleksi dulu datanya. Nah gitu. Nah tujuannya untuk apa? Kita yang pertama menjamin konsistensi, akurasi sama transparansi data tersebut. Sama kita juga ingin mendukung pertanyaan penelitiannya gitu, sesuai apa enggak. Nah, data ekstraksi data ini bisa untuk primary research. Biasanya kalau primary research kita ambil datanya itu dari hasil pengumpulan di lapangan ataupun instrumen penelitian lainnya gitu. Nah, biasanya kalau misalnya kalian ambil yang secondary research, berarti kalian ambilnya itu dari artikel-artikel ataupun jurnal yang udah lolos seleksi gitu. Boleh next? Nah, untuk ekstraksi data di primary research biasanya kita ambil pertama data aslinya itu bisa dari kuesioner, bisa dari catatan observasi, terus juga hasil laboratorium, eksperimen, dari wawancara, dan cara kita mengekstraksinya itu bisa nilainya secara mentah, ataupun hasil pengukuran data tersebut, ataupun kutipan wawancara dari hasil wawancara kita. Gitu. Next. Next. Ya ini ya, sumber data sama bentuknya. Oke, next dulu. Next. Nah, ya oke. Nah, sumber data untuk yang secondary research. Kalau secondary research, biasanya kita ambil dari artikel ataupun studi-studi dari database tertentu. Nah, ini aku mention juga beberapa database yang mungkin kalian bisa pakai, bisa dari PubMed, Science Direct, ResearchGate, Scopus, ataupun Google Scholar, dan juga lain sebagainya. Nah, untuk yang secondary research, bentuk data yang kita ekstraksi itu ada informasi ataupun identitas si penulisnya, lalu desain studinya gimana gitu. Lalu populasinya itu seberapa besar, intervensi atau tindakan yang dibuat itu bagaimana, sama outcome-nya juga bagaimana. Biasanya ada juga kalau misalnya hasilnya tuh kuantitatif gitu, kita lihat mean difference-nya berapa, rasionya berapa, p-value-nya berapa gitu-gitu. Lihat juga misalnya ada risiko bias dari si studi ini. Jadi kita lihat juga gitu, dan kualitas studinya itu seberapa bagus gitu. Tuh, boleh next. Nah, ini aku coba kasih example of tools. Kalau misalnya kita use PubMed, itu gimana? Nah, itu kan pada bagian kiri atas tuh kan pertama kita cari dulu kan. Misalnya kalian cari bisa pakai advance. Nah, di bawahnya itu ada kalian pakai and, or, not gitu kan untuk kalian mau mencarinya. Biasanya tuh kan udah kalian belajar nih kemarin ya pas searching database gitu sama Kak Saf kalau nggak salah. Nah, lalu yang ketiga kalian sesuaikan gitu. Kalian mau yang 5 tahun terakhir, lalu apakah full text, abstrak atau gimana? Terus kayak pakai RCT, pakai meta analisis itu kalian sesuaikan. Sama yang keempat itu kalian klik tanda save yang di atas itu. Nah, tanda save ini kalian seleksi lagi. Kalian mau semuanya atau beberapa ada nanti pilihannya. Dan formatnya itu dalam bentuk pamer apa gimana. Nanti baru kalian create file yang mana itu bisa kalian lanjutkan untuk ekstraksi data. Next. Next dulu. Oke. Nah, untuk tools yang bisa kalian gunakan, bisa kalau misalnya kalian buat datanya itu di spreadsheet, kalian bisa pakai Microsoft. Ini maksudnya kalian bisa pakai Microsoft Excel, ataupun kalau misalnya ambil dari paper based form gitu. Kalian ambil dari formulir surveinya gitu untuk kalian ekstraksi datanya, lembar observasinya bagaimana. Misalnya kalian pas apa namanya kalian lakukan eksperimen gitu kan kalian lihat kan data-data yang udah kalian lihat penelitiannya gimana untuk hasilnya gimana gitu. Nah untuk secondary research bisa dari Ryan, Draftsman, Confidence, sama GBI Summary. Ini agak sedikit typo ya, sorry. Nah, mungkin itu aku kayak cuman kasih toolsnya aja, nggak langsung gimana caranya gitu. Boleh next slide? Oke, sekarang kita bakal bahas tentang quality assessment. Boleh next slide? Nah, dari definisinya sendiri, itu ada di mana kita tuh adalah proses sistematis untuk kita menilai nilai validitas si datanya, keandalannya gimana, risiko yang biasnya gimana dari setiap studinya. Biasanya aspek yang kita nilai itu ada pertama desain penelitian. Desain penelitiannya udah sesuai nggak dengan pertanyaan penelitiannya. Lalu pemilihan sampelnya, apakah peserta ataupun sampel yang dipakai itu udah secara acak atau dia masih representatif gitu. Lalu pelaksanaan intervensinya, ini kelompok yang diperlakukan itu sama enggak gitu dari kelompok 1 sama 2, kecuali kalau misalnya kita melakukan intervensi biasanya kan berbeda tuh, tapi secara dasarnya kelompok yang diperlakukan tuh sama apa enggak gitu. Lalu ada juga pengukuran hasilnya. Outcome yang diukur itu apakah secara objektif atau konsisten atau mungkin ada yang subjektif tiba-tiba pengukurannya. Itu kan kita lihat juga. Lalu ada analisis data. Kita lihat apakah metode statistik yang dipakai di studi itu sudah sesuai apa enggak. Sama untuk kehilangan data ataupun adanya bias gitu. Ini data yang hilang itu udah dilaporkan belum atau udah ditangani dengan benar atau belum gitu. Lalu kita lihat pelaporan hasilnya, apakah semua hasil yang direncanakan itu sudah disesuaikan ataupun yang bias-bias itu juga sudah dilaporkan gitu. Boleh next? Nah, ini mungkin quality assessment tools yang aku kasih secara singkat aja. Misalnya, kalian buat skala penelitiannya itu, assessment-nya itu dalam penelitian rendah, dia sedang, atau dia tinggi gitu untuk nilai-nilainya. Misal, kalian pakai Cochrane Risk of Bial Tools. Berarti kan contohnya itu ada RCT. Misalnya kalian domainnya itu kalian lihat proses randomisasinya itu skala penilaiannya rendah, sedang, atau tinggi. Atau penyimpangan dari intervensinya skalanya berapa. Ataupun data outcome yang hilang itu berapa, pengukurannya outcome-nya gimana, seleksi dari resultnya gimana, itu kalian lihat skala penilaiannya, rendah, sedang, atau tinggi. Biasanya dia tuh dibilangnya low risk, some concern, ataupun high risk of bias gitu. Nah, kalau misalnya skala kalian itu Newcastle atau skill itu biasanya kalian pakainya untuk yang observasional, bisa cohort, case control gitu contohnya. Dan itu skala penilaiannya tuh pakai bentuk skor. Misalnya 1 sampai 0 sampai 9, 0 sampai 4, 0 sampai 2. Dan itu nanti aku ada juga next slide-nya tuh bakal ada contoh-contohnya itu. Lalu ada CSP checklist gitu. Nanti kita tuh kayak ada pertanyaan-pertanyaannya. Nanti pertanyaan-pertanyaannya nanti kita lihat ya skala penilaiannya tuh udah yes, no, can't tell, dan itu biasanya untuk studi kualitatif. Misal, apakah tujuan penelitian itu udah jelas atau belum? Tuh. Nah, yes, no, or tidak bisa tidak jelas gitu. Lalu metodenya udah sesuai untuk menjawab dari tujuan awal atau belum gitu. Ataupun desain penelitiannya ada dijelaskan atau enggak gitu. Nah, itu untuk checklist-checklistnya. Biasanya itu ada pertanyaan-pertanyaan yang kita jawab gitu. Nah, kalau misalnya kalian pakai GPA Critical Appraisal Tools, itu berarti checklist juga, dan biasanya itu studinya itu bisa di berbagai study, bisa RCT, cohort, case report, dan lain sebagainya gitu. Dan untuk skala penilaiannya itu ada yes, no, unclear, sama non applicable. Dia bisa misalnya kita nilai desainnya sama juga, hampir mirip juga gitu sama CSP. Dan terakhir itu ada Amstar to Tools. Itu kalau misalnya kita skala penilaian itu kritis, moderate, atau rendah. Misalnya pada systematic review, kita lihat apakah pertanyaan penelitian itu sudah jelas dan itu seberapa jelas gitu, udah kritis, moderate, atau rendah gitu. Ataupun strategi dari pencarian dari berbagai database-nya itu udah kritis, moderate, atau rendah. Itu contohnya. Boleh next slide? Nah, ini ya, untuk example-nya, misalnya contohnya yang di studi observasional kita pakai NOS. Kita lihat selection-nya itu, atau apakah respondennya itu udah dipilih secara acak gitu, dan seberapa acak poinnya. Ternyata penilaiannya dari 0 sampai 5, dia 4 gitu. Kalau comparability-nya, compare-nya itu udah bagus nggak, udah sesuai nggak. Misalnya awalnya kalian pakai yang dia tuh misalnya usianya remaja, yang menjadi compare-nya apakah dia usianya sama juga, ataupun tingkat pendidikannya itu sama juga, atau apakah ada perbedaan gitu. Oh, ternyata sama, berarti nilainya 2 gitu. Kalau misalnya skalanya 0 sampai 2 gitu. Nah, untuk outcome-nya sama gitu juga. Misalnya penilaiannya 0 sampai 3. Ini apakah alat ukur untuk knowledge, attitude, dan praktisnya itu udah tervalidasi berapa gitu. Jadi kita nilai juga gitu. Lalu kita totalkan skornya. Misalnya totalnya tuh bagus nih, 9 per 10. Itu bisa nih kita cari skornya berdasarkan misalnya 9 dibagi 10 dikali dengan 100%. Udah, kita kan dapat nih persentasenya. Nah, untuk persentasenya biasanya aku pakai misalnya persentase dari 80 sampai 100%, itu berarti kualitasnya itu tinggi. Berarti studinya itu udah dirancang dan juga udah risiko biasnya itu udah rendah dan apa ya studinya itu udah baik gitu. Kalau misalnya dia itu dari angka 60 sampai 79% gitu. Berarti itu kualitasnya tuh sedang atau moderate kita bilang. Jadi berarti ada beberapa kelemahan yang minor sebenarnya. Tapi dia tuh nggak terlalu mempengaruhi si validitas utamanya gitu. Nah, kalau misalnya kurang dari 60% gitu, berarti udah kualitasnya itu rendah, risiko biasnya juga tinggi, terus juga biasanya kita tuh perlu hati-hati banget kalau misalnya mau menafsirkan studi tersebut. Nah, itu kalau misalnya sebelah kanan tuh ada systematic review dengan AMS1. Nah, kita lihat pertanyaan, kita nilainya tuh, ya kan kita lihatnya dia kritis, moderate, atau rendah gitu kan. Jadi kita lihat pertanyaan penelitiannya tuh udah jelas apa enggak, apa dia udah mengikuti format PIKU atau belum gitu. Oh ternyata udah, kita centang gitu. Lalu strategi pencarian komprehensifnya, udah berapa database? Ternyata banyak, sampai 5 database gitu. Oh berarti bagus gitu, udah kita centang. Lalu kita lihat seleksi studi oleh lebih dari satu penilai independen. Ternyata enggak, dia itu cuman dilakukan oleh satu penilai aja, enggak lebih dari satu. Berarti kita salahkan gitu. Lalu kita lihat penilaian risiko bias dari studi inklusinya. Ternyata dia udah pakai tools yang bagus gitu, misalnya NOS gitu. Oh, berarti udah bagus nih. Lalu kita lihat pertimbangan bias dalam interpretasi hasilnya. Ternyata dia tuh disebutkan, tapi nggak rinci. Jadi agak kurang sesuai. Jadi kita pakai tanda yang panah itu, tanda apa? Tanda seru. Lalu terakhir kita analisis, misalnya bias dari publikasinya, ternyata tidak dilakukan gitu. Ya udah berarti nggak sesuai. Nah kita lihat kualitasnya. Ya, kalau misalnya kategorinya itu tinggi, biasanya semua domainnya itu domain-domain yang penilaian dari 1 sampai 6 itu semua terpenuhi. Jadi itu udah risiko biasnya udah rendah dan udah apa ya reviewnya itu udah dilakukan dengan baik gitu. Kalau misalnya dia moderate atau sedang, biasanya itu ada beberapa kekurangan-kekurangan kecil pada domain-domain atau poin-poinnya kayak gitu, sehingga kesimpulannya itu sebenarnya masih dapat dipercaya gitu. Cuman ya agak sedang gitu lah penilaiannya. Nah, kalau misalnya dia low atau rendah, berarti ada banyak kelemahan di poin-poin yang tadi gitu. Sehingga kesimpulannya apa? Ini nggak sepenuhnya akurat tadinya. Sama yang terakhir itu ada critical low atau kualitasnya itu sangat rendah. Sehingga banyak banget kelemahan dari domain-domainnya gitu. Sehingga kita tuh nggak bisa pakainya gitu. Atau hasilnya tuh sangat rendah gitu. Lalu boleh next slide? Next slide. Oke, sekarang kita ke bias yang ada di research tool. Nah, jadi bias itu kan kesalahan sistematis yang bisa mempengaruhi hasil dari penelitian kita. Biasanya itu kan karena kita keliru dalam hal research-nya atau desain atau pelaksanaan dari studinya. Nah, ini bias itu sebenarnya ada banyak, cuman yang paling common atau yang paling umum biasanya terjadi itu ada 6 ini, recall bias, reporting bias, selection bias, detection bias, sama yang lainnya. Mungkin boleh next slide. Nah, kita bahas dulu dari selection bias gitu. Nah, dia itu pemilihan pesertanya tuh nggak acak ataupun tidak mewakili populasi targetnya. Misal, dia itu dalam penelitiannya tuh ingin meneliti tentang diet pada anak sekolah, tapi dia cuman ambil pada anak SD doang, SMP sama SMA dia nggak ambil gitu lah. Berarti kan nggak acak gitu, atau nggak mewakili dari populasi target yang seharusnya gitu. Ataupun misalnya dalam penelitian kita terkait dengan efek obat, lalu kita intervensi pasiennya itu ke pasien muda, sedangkan kelompok kontrolnya itu pasiennya itu lebih tua. Itu kan harusnya bias, jadi kayak ada perbedaan dan itu nggak mewakili gitu, harusnya kan harus sama gitu. Nah, kalau cara cegahnya gimana? Ya kita harus randomisasi atau harus pakai apa ya caranya RCT lah gitu. Sama kita jelaskan juga harus ada kriteria yang kita inklusi atau kita eksklusi dengan jelas. Jadi kayak yang kita masukkan ke dalam peserta atau ya pesertanya itu inklusinya ini aja yang harus ada ataupun yang eksklusi yang tidak boleh ada ini. Jadi harus jelas gitu biar sesuai dan juga sesuai dengan target yang diinginkan. Lalu performance bias gitu. Peserta atau peneliti tahu siapa yang menerima intervensi. Nah, ini biasanya itu tuh dia itu nggak blinding ataupun entah itu peserta ataupun penelitinya itu udah tahu duluan gitu terkait dengan intervensinya sehingga itu tuh bakal mempengaruhi bias gitu. Misal kalian tuh buat studi tentang diet. Terus ada peserta yang tahu ternyata dia itu sedang dapat diet sehat gitu. Jadi dia tuh udah lebih disiplin olahraga daripada si kelompok kontrolnya. Nah, itu kan bisa buat bias ya, karena mereka udah tahu duluan gitu. Ternyata mereka ada juga udah disuruh mendapat yang diet sehat gitu. Nah, itu cara cegahnya gimana? Berarti kita harus blinding atau kita nggak boleh sampai si peserta ataupun peneliti tahu siapa yang menerima intervensi itu. Nah, untuk yang ketiga itu ada detection bias. Jadi kita pengukuran outcome itu dilakukan secara subjektif, bukan objektif. Harusnya kita kalau misalnya mengukur sebuah outcome dari studi yang kita jalankan, itu kan harus secara objektif. Nggak boleh secara subjektif doang. Misalnya kita istilahnya cuman anamnesis doang. Kita nggak lihat pemeriksaan fisiknya gimana. Walaupun sebenarnya anamnesis juga cukup membantu, tapi kan kita harus secara objektif gitu. Harus ada pemeriksaan fisiknya, harus ada lab, pemeriksaan penunjangnya biar lebih nggak bias gitu. Kalau cuma subjektif doang kan kita belum tentu itu benar gitu. Jadi biasanya itu eh, karena nggak objektif. Jadi cara cegahnya gimana? Ya udah dia si penelitinya itu harus gunakan alat ukur tertentu yang objektif dan juga valid sesuai dengan pengukuran yang dia ingin ukur gitu. Em, Lalu ada attrition bias. Biasanya ini peserta berhenti untuk ikut karena efek samping ataupun bisa karena dia bosan gitu. Biasanya itu banyak nih peserta-peserta awalnya dia ikut, ternyata di akhir-akhir penelitian dia udah nggak ikut nih atau udah drop out lah. Akhirnya nggak sama antara kelompok satu dengan kelompok lain yang ingin dibandingkan gitu. Sehingga itu bakal bias. Misalnya awalnya kita uji nih, ada 30 orang kelompok satu, 30 orang kelompok dua untuk diuji. Lalu ternyata setelah udah beberapa lama, kelompok satu berkurang, kelompok duanya tetap orangnya. Nah, itu kan nggak sesuai nih, karena hasilnya tuh pasti bakal bias gitu kan. Karena ya udah beda, awalnya udah 30 orang, ternyata akhirnya tuh udah 15 orang gitu. Itu kan udah mempengaruhi outcome ataupun kalau misalnya kita analisis datanya itu udah nggak sesuai, itu udah bias gitu kan. Biasanya itu seringkali terjadi kalau misalnya pesertanya itu udah kehilangan motivasi terkait dengan apa yang ingin diteliti itu. Jadi kayak kita tuh harus upayakan kita tuh benar-benar harus follow up lah si pesertanya dengan baik gitu. Lalu kelima ada reporting bias. Biasanya berarti hanya melaporkan hasil yang signifikan aja atau p-value-nya itu kurang dari 0,05 itu berarti hasilnya signifikan dan nggak melaporkan hasil-hasil yang udah negatif. Nah ini biasanya bisa pas kalian mau publikasi. Biasanya kan kalau publikasi itu pasti jurnal-jurnal ini suka dengan studi-studi yang hasilnya tuh positif gitu. Jadi lebih sering dipublikasikan. Itu sebenarnya nggak boleh karena udah bias duluan. Yang sebenarnya dia dalam penelitian itu ada negatif atau hasil yang memang kurang ada netral ataupun negatif, tapi dia nggak masukin ke dalam itu sehingga udah bias. Jadi itu lumayan sering gitu. Misalnya ada peneliti dia melaporkan bahwa obat A ini menurunkan tekanan darah, tapi dia nggak nyebutin efek sampingnya ada apa misalnya ada nyut jantungnya gimana gitu ataupun dia nggak menyebutkan hasil-hasil negatif dari obat tersebut apa gitu, itu bisa bias gitu kan, itu kan nggak sesuai gitu. Nah, cara cegahnya gimana? Ya udah, kita berarti harus lapor semua hasilnya, termasuk yang nggak signifikan pun kita harus lapor gitu. Yang terakhir ada recall bias. Nah, ini biasanya bergantung pada ingatan peserta yang terbatas. Nah, misal kalian buat penelitian terkait responden, eh, diminta nih dia ingat dia konsumsi makanan apa aja selama 1 tahun terakhir gitu. Ya pasti respondennya ingat-ingat lupa gitu kan. Jadi kayak nih nggak akurat gitu pastinya. Dan itu kan bergantung pada ingatan pesertanya gitu kan. Jadi kayak entah iya entah enggak dia jawabnya itu. Jadi kayak cara cegahnya gimana? Berarti kita harus gunakan data dari misalnya kalau misalnya di rumah sakit kalian bisa gunakan rekam medis ataupun catatan-catatan objektif lainnya gitu. Nah, mungkin ada beberapa lain yang nggak aku mention, misalnya confirmation bias, measurement bias, dan juga planning bias tuh bisa mungkin nanti cari sendiri itu. Kayak boleh next slide. Nah, mungkin itu dari aku. Terima kasih. Kalian bisa isi post testnya dulu ya.
Mungkin untuk Fikri bisa di-share untuk link post testnya. Dan mungkin sekarang untuk question and answer dulu terlebih dahulu ya, Kak. Oke.
Boleh.
Mungkin dari teman-teman atau peserta lain, apakah ada yang ingin bertanya? Boleh raise hand. Oke. Di layar aku ada Kak Dina Nadira terlebih dahulu. Boleh bertanya, Kak?
Oke, izin tanya terus ya. Semuanya terima kasih banyak untuk pemateri yang udah menyampaikan materi dengan kalian, dan terima kasih banyak untuk teman-teman panitia udah mempersilahkan aku untuk bertanya. Jadi pertanyaan aku kan gini, misalnya nih pas penelitian, terutama penelitian yang kualitatif di mana kita tuh cari-cari referensi bacaan. Nah, dan kita tahu juga kalau penelitian itu dia biasanya kita nggak buat sendiri, kita buatnya per tim. Nah, setiap orang cari jurnal yang berbeda dan setiap orang punya sudut pandang yang berbeda. Nah, itu gimana caranya kita meminimalisir bias ataupun gimana ya supaya gimana caranya supaya kita bisa meminimalisir bias dari perorangan sehingga dia tuh nggak mengaruhi tulisan kita. Itu saja, terima kasih.
Ini langsung dijawab atau gimana?
Bebas Kak, boleh atau ditampung terlebih dahulu dan lanjut ke...
Ini aku langsung jawab aja ya.
Oke, Kak.
Nah, tadi kan kalau misalnya kalian buat penelitian tapi bareng-bareng nih, terus kalian beda-beda pendapat, apalagi kalau misalnya penelitiannya kualitatif gitu. Nah, biasanya kalian tuh harus kayak misal kalian ini kan bareng. Satu ambil dari jurnal A, satu ambil dari jurnal B, tapi nanti jurnalnya tuh bakal kalian gabung gitu. Nah, itu berarti kalian ini bakal diskusi lagi. Kalian pertimbangkan lagi kenapa kalian ambil jurnal itu, kenapa kawan kalian merasa jurnal itu nggak relevan gitu. Nah, udah nih kalian udah pertimbangin, oh aku pilih studi ini karena dia ini. Terus kawan kalian kayaknya nggak cocok nih dengan penelitian kita ini. Nah, kalau misalnya kalian udah buntu nih, apakah kita ambil nggak ya jurnalnya? Nah, itu bisa kalian tanya ke peneliti-peneliti lain yang kalian anggap dia tuh udah jago lah di bidangnya. Nah, tanya ke peneliti tersebut. Nah, kalau jurnal ini, kalau boleh nggak kita masukin gitu? Apakah relevan dengan studi yang kita ingin buat atau enggak gitu. Nah, jadi itulah kenapa kita tuh kalau dalam meneliti, apalagi dalam kerja tim itu nggak boleh cuman satu peneliti aja gitu yang melihat jurnal-jurnal yang ingin kita ambil gitu. Jadi kayak kalian lakuinnya bareng-bareng biar kalian tahu ternyata pas kalian lihat nih, oh ternyata bagus, terus di komen sama kawan kalian, kayaknya nih kurang di sini. Kalian nyadar ternyata ada kekurangan juga ini si studi ini. Akhirnya apa? Kalian nggak jadi ambil gitu. Nah itulah fungsinya kalian tuh bekerjanya itu bareng-bareng gitu dalam kelompok. Tapi kalau misalnya kalian udah stuck nih dua-dua ataupun kawan-kawan kalian yang satu kelompok udah juga stuck, bisa nih kalian minta bantu ke peneliti-peneliti lain yang memang udah jago di bidang tersebut untuk menilai studi ini bagus nggak untuk kalian masukkan ke penelitian kalian sebagai latar belakang atau apa namanya tinjauan filsafatnya gitu. Apakah cukup menjawab?
Menjawab, terima kasih banyak, Kak.
Oke, terima kasih Gina.
Oke, untuk selanjutnya di layar aku ada Kak Syifa. Boleh bertanya, Kak?
Baik, terima kasih Kak Ina sudah mempersilahkan. Terima kasih juga kepada pemateri kita malam ini. Izin tanya Kak Hayfa. Misalnya aku punya dua penelitian dan penelitianku tuh mirip. Jadi ada penelitian diabetes tipe 1 sama diabetes tipe 2. Aku mau jadiin itu dalam satu paper. Tapi aku gunainnya tuh yang diabetes mellitus tipe 1 tuh aku gunain quality assessment-nya tuh yang Cochrane. Dan diabetes mellitus tipe 2 tuh aku gunain yang quality assessment yang New Settle. Nah, gimana caranya itu agar aku bisa rampungin dua penelitian yang beda quality assessment tuh dalam satu paper yang ingin aku buat itu, Kak. Terima kasih.
Oke, terima kasih Cipa. Aku izin jawab ya. Nah, jadi kalian kan buat penelitiannya ini beda. Satu, kalian buat diabetes tipe 1, yang satunya kalian buat diabetes tipe 2. Otomatis hasilnya juga bakal beda kan, tergantung dengan peserta atau respondennya gitu. Nah, misalnya kalau kamu pakai jadi yang tipe 1 yang Cochrane ya, yang tipe 2 baru Newcastle gitu. Nah, itu boleh kamu pakai satu yang Cochrane, satu yang Newcastle sesuai dengan assessment yang kamu berikan ke respondennya ini udah sesuai dengan apa yang kamu inginkan, udah sesuai dengan pertanyaan yang ingin kamu jawab di awal di bab 1 itu atau enggak gitu. Nah, kalau misalnya kamu udah dapat nih datanya yang tipe 1 berbeda sama yang tipe 2, maka kamu masukkan dua-duanya gitu dalam penelitian tersebut gitu. Jadi misalnya yang tipe 1 hasilnya A, tipe 2 hasilnya B. Nah, ini kan beda dan pada dasarnya sebenarnya penelitian kamu juga lumayan beda, satu yang tipe 1, satu yang tipe 2. Jadi kayak dua-duanya itu dimasukkan. Kamu jelaskan juga misalnya tipe 1 pakai uh, toolsnya ini dengan outcome-nya atau outcome ini melalui intervensi yang itu gitu. Jadi kayak misalnya yang diabetes tipe 1, kamu pakai Cochrane, skala penilaiannya tuh ada rendah, sedang, tinggi, itu kamu jelaskan, terus juga hasilnya gimana atau outcome-nya gimana. Lalu jelaskan juga yang diabetes tipe 2 pakai Newcastle, skala penilaiannya itu dalam range angka misalnya 0 sampai 10, itu kamu jelaskan kenapa pakai itu dan outcome atau hasilnya itu gimana gitu. Jadi dua-duanya dimasukin ke pembahasannya itu. Apakah cukup mengerti?
Baik, Kak. Terima kasih banyak.
Oke.
Oke, aku juga izin bertanya ya, Kak. Aku mau tanya, tadi aku agak kurang paham di bagian most common of bias-nya kan ada selection, ada performance, detection, dan segala macam ya, Kak. Nah, kalau misal ada satu jurnal yang dia itu nggak dilakukan blinding gitu, berarti kan, atau misal nggak dilakukan randomized, tapi yang lain-lainnya tuh dilakukan gitu Kak, tapi kayak cuman salah satunya aja yang nggak dilakuin gitu, itu berarti auto kita anggap nggak valid atau kayak masih bisa kita pakai ya Kak? Atau kayak harus bener-bener full requirements itu harus bagus semua gitu? Nah, cukup sekali.
Nah, itulah oke, aku izin jawab ya, Ines. Nah, jadi itulah kenapa kita harus ada yang namanya quality assessment untuk kita menilai dia tuh udah sesuai nggak sama apa yang kita inginkan gitu, udah menjawab pertanyaan penelitian yang awalnya kita tanyain apa enggak gitu, ataupun si penelitinya tanyain gitu. Jadi kalau misalnya menurut kamu dari hasil kamu quality assessment itu ternyata rendah, misalnya kamu ternyata rendah nih, yaudah aku kayaknya nggak pakai deng, aku coba pakai jurnal lain yang memang bagus gitu, yang quality assessment-nya itu tinggi, yang persentasenya itu tinggi. Jadi kayak sesuaikan lagi sama pertanyaan kamu mau nggak pakai yang itu? Takutnya nanti kan bias kan. Jadi kayak mending nggak usah aja. Jadi coba nilai dulu quality assessment-nya bagus apa enggak. Nanti baru kamu lihat kamu pakai apa enggak gitu.
Oke, Kak.
Cukup menjawab?
Oke, ya, Kak.
Oke.
Bentar, Kak. Berarti tadi lebih baik nggak dipakai aja ya, Kak. Mending cari yang jurnal lain yang emang lebih memenuhi gitu ya, Kak.
Ya, itu tergantung sama persentasenya. Misalnya menurut kamu persentasenya tuh sedang ke tinggi. Oh, menurut kamu masih layak nih untuk dipakai. Ya udah kamu pakai. Tapi kalau misalnya rendah banget persentasenya, ya menurut kamu terlalu bias. Jadi kayak hati-hati banget kalau misalnya mau pakai gitu. Tapi bagusnya emang enggak gitu.
Oke, Kak. Baik, mungkin
Oke.
dari aku segitu pertanyaannya, Kak. Kalau dari teman-teman dan peserta lain masih ada yang mau bertanya, atau kalau sudah tidak ada, mungkin kita bisa lanjut ke next session, yaitu post-test ya. Post-testnya bisa dikerjakan ya teman-teman sampai 19.52. Sambil menunggu teman-teman mengisi post-testnya, untuk Kak Haifa bisa untuk dokumentasi ya, Kak. Dan penyerahan sertifikat juga. Aku serahkan ke Fikri untuk screenshotnya.
Oke, makasih Ina. Eh, oke, di sini aku selaku mewakili juga dari SRI kepada Hayfa karena sudah meluangkan waktunya bisa mengisi training di Scorecord ketiga. Semoga ilmu yang disampaikan oleh Hayfa bisa bermanfaat untuk kita semuanya ya. Ini ada sertifikat Hayfa dari Score Cinta. Di sini aku izin ambil dokumentasi. Mungkin yang pertama itu kita bisa gaya formal terlebih dahulu Hayfa. Oke, aku izin screenshot ya. Satu, dua, tiga. Oke, untuk kedua itu scoring. Satu, dua, tiga. Oke, terima kasih Haifa.
Oke, terima kasih Fikri.
Oke, baik. Untuk peserta boleh sambil mengerjakan post testnya. Dan untuk Kak Haifa, jika masih ingin stay di Zoom, boleh ya, Kak. Tapi kalau misalnya Kakak ada kesibukan lain, boleh untuk ke live Zoom-nya, Kak. Terima kasih.
Oke, mungkin aku izin nutup sedikit ya. Mungkin sekian aja dari aku. Mohon maaf kalau misalnya materi aku mungkin agak salah atau gimana. Mohon maaf juga kalau misalnya ada salah kata. Terima kasih juga kalian udah dengar. Akhir kata aku izin pamit ya. Terima kasih semuanya.
Terima kasih banyak Kak Haifa atas materinya. Sangat bermanfaat.
Oke, terima kasih.
Mungkin untuk rundown selanjutnya, itu ada pemateri dari em, yang kita tunggu-tunggu ya teman-teman dari Prof. Erik. Mungkin akan dilaksanakannya di jam 8. Jadi untuk teman-teman diharapkan untuk tetap stay di Zoom ya. Makasih.
like to thank organizing committees because you have worked very hard and you have held a lot of these events, and to the participants as well. And I hope that you will gain knowledge here, and you can ask for the professor like anything, okay? Because yeah, the professor is so friendly, and you can chat him and you can even call him. I think that's from our forwards. Without any further ado, I will return this.
Okay, thank you, Kak Amar, for the words. Now, for the participants, you guys can fill out the pretest. And we can wait until 8:15 to fill out the quiz. And while waiting for that, I would like to read the CV of our speaker tonight, Prof. Eric. Okay, so Prof. Eric has a BA degree in English from Presbyterian College and also BS in biology, and then the postgraduate diploma in English literature, and then for the medical school in Medical University of South Carolina. And then he also has completed the residency in neurosurgery in Emory University, and then the fellowship in the pediatric neurosurgery department in Emory University. And as you can see also in the screen, there are many of his accomplishments and his committees, honors, and then his research projects, as you can see here. So the materials that he will give us tonight would be very beneficial for us all. So I hope you guys can follow, listen to what Prof. Eric will give us. Okay, now wait the pretest.
By the way, Professor, while we are waiting for the participants to take their pretest, how was your day?
Oh, it's been good. It's been good. How have you been?
I've been great. Yeah, we've been doing some works actually related to this topic as well, especially in research. Last week we held this similar kind of event, and yeah, today for the closing one, we invited you as our speaker, and we are very, very honored to have.
No, likewise. I mean, the honor is mine. I really enjoyed meeting you guys when I was in Surabaya a couple months ago.
Yeah, so for those who have not known, I met Prof. Eric in Surabaya, and together we chat a lot. And yeah, I recently invited him to attend our event here in SCORE. And I hope that all of you participants can get some knowledge from the professor. Okay, I will return this to Ines. Thank you.
Okay, may I ask, Prof, for the materials, will you share the screen for yourself, or do you need my help to share the materials?
Oh no, I've got it. Here,
Okay.
let me make sure that you guys can see it.
Okay.
Let's see. Can you see me?
Yes. Yeah, it's showing.
Beautiful. Awesome. Awesome. So first of all, a couple things. I want you guys to be relaxed. I am going to go through this pretty quickly. And one of the reasons why is because I don't want to waste a lot of time on my stuff. I want to hear from you. During the presentation, if I say anything that you have a question about, feel free to ask. You can also ask in the chat. And if someone will break in, if there's a question in the chat, and just let me know, because I'm not going to look at the chat. But if you have a question during the talk that you really want to get out, feel free, okay? So I gave a lot of thought about this talk and like what I wanted to tell you about research, because it's something of mine where it's a real passion. And this is my original title, Putting Research into Clinical Practice. And I changed it to Creating Research from Your Clinical Practice. And the difference is it's not so much seeing how you can use research in a clinical practice, but it's a two-way street of both researching what you're doing and allowing your research to change what you're doing in your clinical practice. And when you can have that conversation between your research mind and your clinical mind, I think is when you do your best work. So first of all of you are in medical school, correct? Yeah, so you're all going to be clinical doctors. So the first question that would come to mind, because clinical doctors are super busy, is why would I want to make myself even busier by doing research? And I'm going to give you the argument as to why I think if you have the thought to do research, you should be doing research as a medical doctor, okay? So there are a lot of PhDs who are doing research, and that is great research, but they have a focus on just the science. As medical doctors, we have a focus on the patient. As a doctor, your focus better be on your patient, or else your patient's not going to do well, right? Wouldn't it be beautiful if you had somebody who had that scientific mind and also had the ability to make an impact on other people? And I'm going to tell you a story about my hero, who I think was one of the first clinician scientists in neurosurgery. This is, first of all, this neurosurgeon is Dr. Victor Horsley. He was a neurosurgeon from the United Kingdom, England at the time. And besides the fact that he has the best mustache of any neurosurgeon I've ever met, he had the esteemed honor of being one of the first clinician scientists, meaning that he was both a researcher and a neurosurgeon, successful neurosurgeon. So I know many of you are probably not going into neurosurgery. The minority of you are going to go into neurosurgery. And so these things may not make any sense to you, but trust me, he did big things. So stereotactic neurosurgery, that's our ability to know exactly where we're sticking something in the brain. Very important, because the brain, it turns out, is a complicated structure. He developed the frame for stereotaxis, allowing us to put somebody's head in one spot and be able to guide things in a very precise location. He was one of the first to define the motor cortex of the brain, and he described the use of bone wax. He was one of the first to describe the use of bone wax. This is what we use to stop bleeding in the operating room. In his bench to bedside work, and that is research to clinical practice work, he literally researched the brains of monkeys and was just using electrodes to figure out what part of brains cause different parts of the body to work. And he used that research to remove one of the first cortical scars to treat a little boy who had epilepsy that was just not responding to anything else. He essentially went in, took out a cortical scar out of the brain, and cured this young child of epilepsy. One of the first to describe it, one of the first to do it. So raise of hands. Can anybody tell me what this is right here? And Rice, you're interested in neurosurgery, so you should be able to tell me what that's called.
I think I will give this floor to the audience, Professor, because they are the one who needs to.
Okay, fair enough, fair enough. Anyone? So this is called the homunculus, okay? The homunculus, or the little man. And this is the representation that we all have in our brains. So, and I'm sure you guys have learned about this. So this is the central sulcus. This is the precentral gyrus, which is for motor function. So at the center of your brain, you've got your legs, and then your arms, and then your face. And then you have a representation behind that central sulcus and the post-central gyrus for somatosensory. Now, can anyone tell me who is the main descriptor for the homunculus? A little bit of history here. So this is a guy who, in the United States and in Canada, we fight over him. His name was Wilder Penfield. So if you're ever in the operating room and somebody asks for a Penfield 1, 2, 3, or 4, these are all instruments, that's named after Wilder Penfield. And so if some smarty pants neurosurgeon asks you about Penfield, you'll know about Penfield. We always say he was the first to describe the homunculus, but in fact, it was my guy, Victor Horsley, who did a more basic description of that homunculus than Wilder Penfield. But my point here is that these things that we see in research, we can employ in our clinical practice. So my own background, how did I get into research? So as we talked about, initially I had an English literature degree, so I was nowhere near research. I went to a small liberal arts school where I didn't do any research. I had no laboratory experience. I did not touch a micropipette until I had made it to medical school. While I was I knew that I wanted to do surgery, and then I sort of localized that to neurosurgery. And while I was in the operating room with a gentleman by the name of Dr. Sunil Patel, he was stimulating little parts of the brainstem, and he was seeing just differences in blood pressure and heart rate. And that is what sparked that interest in me. I've got to get in on this research thing, because it was just fascinating to me that he was able to do this. And this was all clinical research, and I wanted to do some basic science research. So the first thing that I did was I did a Ph.D. I looked at estrogen as a neuroprotectant in spinal cord injury. And then afterward, I looked at progesterone as a neuroprotectant in traumatic brain injury. And so I had myself set up for a career looking at sex steroids and their use as neuroprotectants in traumatic brain injury and spinal cord injury. And this is what I want to tell you, is that one of the frustrating but actually fun parts of research is that your research will fail, okay? So as I've got this career in my brain set up that I'm going to work on progesterone, we had a clinical trial, and you can read up on this in the New England Journal of Medicine, 2014, where two major clinical trials, I mean, you're talking about like almost 1,500 patients between these two trials, I think maybe even more than that, completely showed that progesterone did not work in traumatic brain injury. And because I'm the type of person where I will kind of be very optimistic. After all of that, I even sent in a grant for use of traumatic brain injury in juvenile animals with the argument, well, it failed in adults, but why don't we try it in juveniles? And it was, I've never had a grant from killed from such a high level. It was like, the president assassinated my grant. Like the head of the training grants at the NINDS literally called my my boss and said, do not submit another grant like this. These will never get funded. So what are you to do when your life plans have been completely smashed? So first of all, why would things work in animals but fail in humans? So part of it is how we define what a traumatic brain injury is, and we don't have very good descriptions for that. So the most typical thing that we use is the GCS, which is pretty quick and dirty, the Glasgow Coma Scale. The other things that we use are the Glasgow Outcome Scale, another very quick but very dirty way of assessing how people recover from traumatic brain injury. So if you're going to make an impact with one of those scales, it's got to be a huge impact for you to even be able to see it. The other problems with looking at brain injury in patients is that there are a lot of comorbidities, less so in children than there are in adults. But in adults, I mean, we all know, you have people that smoke, you have people that drink, you have people that diabetes, high blood pressure. All of these things can impact your outcome. There's a varied clinical practice. Anybody who's worked in more than one hospital knows that you have these doctors who, this is how I treat, X, Y, or Z. This is how I treat this disease process. I don't care what the research says. This is how I'm going to do it. And that can introduce a lot of variables into your research. You don't have those types of variables when you're treating a bunch of rats, pigs, or mice. You get to control everything. And then our own biases. Unfortunately, what you will find is that when you believe in your research, believing in your research can impact the results in ways that it's not like you mean to do it, but you can kind of, you sort of just naturally influence your own results. The other thing that can happen is that maybe you don't find what you were looking for in one series of tests. You don't report that, but you do find what you're looking for in another series of tests, and you do report that. And so what everybody is reading in the literature is all positive results. So that's just ways that bias can creep into the literature. We're using these blunt measures of outcome, the Glasgow Outcome Scale. And then you have these two competing forces. You want to do really good work, but it costs a lot, whereas you can do something for a little bit cheaper, but it's not quite as robust. And so constantly you have quality competing with trying to keep costs down. So really for me, it was about finding a new pathway in research and really thinking about, I knew I wanted to stay in neurotrauma, but I wanted to find a new pathway toward neurotrauma. So I completely shifted my paradigm. And what I really started doing was looking at critical care and looking at how the body responds to traumatic brain injury. So it turns out that after you have a traumatic brain injury, can you guys see my cursor here? Okay, perfect. So after you have a traumatic brain injury or any kind of really bad trauma, you get a huge pro-inflammatory response, okay? And we can see that in our patients. They get febrile, they release all of these cytokines. But what's actually going on that we don't always see is that in response to that pro-inflammatory response, you actually get an anti-inflammatory response. The body tries to cool down the immune response. And so what you end up seeing is a suppression of your immune response. And so if anybody has ever had a patient where they're in a really bad trauma, when I was in Surabaya, I saw a ton of people riding on those motorbikes. And, most of them had on helmets, but there were a lot of motorbikes. So my guess is you guys see a lot of motorbike collisions and motorbikes versus cars. So you probably see some pretty banged up folks. If you ever get one of those patients and you stabilize them, right, you think they're doing great. And then maybe 3 to 4 days later, your very stable patient gets a ventilator associated pneumonia. And you're like, where did that come from? This is where that came from. Okay. So you had that big injury, you had that huge pro-inflammatory response. And what ends up happening is that the body responds by essentially making an anti-immune response, and then that sets you up for an infection. And what my research is trying to do is figure out how I can temper this, how I can slow this down and improve the immune response after the injury so that you reduce the risk of infection after the injury. And in research, the struggle is real. I never actually saw this sport when I was in Indonesia, but this is amazing. And I don't think you guys get enough credit for, and I'm not even going to try and pronounce it. It's like takraw. Somebody help me here. What's it called?
Yeah, Professor, it's called takraw.
Takraw. Yeah. I'm still learning. My Indonesian is still, I'm still learning it. But takraw is amazing. And I feel like it's a metaphor for research where you really, like, it's got to be very precise and you've got to really try at it. And for research, the struggle is real. There are financial constraints. You have time constraints. As a doctor, you have to see enough patients, but you also have to spend enough time in the lab. You constantly have to struggle for funding. And trust me, in the United States right now, that is a real struggle because a lot of our funding is getting cut with this new administration. There's a constant struggle with writing. Like, you constantly have to be writing. You constantly have to be editing. Statistics, you either have to have a good statistician or you really have to know your statistics or you'll run into trouble very quickly. And what you'll find, like right now as a student, when I was a student, I used to think that that what I was worried about was money. What I was worried about was, getting enough time to read and to, study. As a doctor, what really impacts you is time and getting enough time, because you have to set aside time for clinic, you have to set aside time for surgery, and then what misses out is oftentimes your research. But it's very, like, if you can make a career with or in research, it can be very enlightening, and it can really help you in terms of impacting your career. And so the advice that I would give to you as a young student, as a young clinician, is to say yes to many different things. Now, don't say yes to everything, right? So you have to have a rationale. You have to have a passion. And everybody needs to figure out what their passion is. For me, it's neurotrauma. If something is related to neurotrauma, I will generally say yes, and then I'll figure out how to incorporate that. But if somebody came to me and was like, I want to study kidney disease that is related to high blood pressure, I'd say, that is beautiful. I love that for you. I don't love that for me, because while I'm fascinated by the kidneys and I'm fascinated by high blood pressure, it's outside of my scope. So you have to define your research area. As you're saying yes to everything, figure out what you actually love, right? And then hone in on one topic, because you can't do everything, okay? And become an expert in that topic. And where you should be an expert. So, like, when I talk to my colleagues about what I do in neurotrauma, the neurosurgeons get the neurosurgery part, and the critical care, like the ICU doctors, understand the immune part, but not everybody gets it. And that's the sweet spot right there, because you can really become an expert. You're taking two different fields and you're melding them together. And that's where you define a niche, okay? And you have to define your niche. So a basic biological principle is that two species that feed on the same thing cannot exist in the same location, because they'll compete, and then one of them will win and the other one becomes extinct. Does that make sense? So what you have to do when you're defining your research is make sure that you have a niche that you can feed on that nobody in your location is doing, okay? And that is hard to wrap your mind around. So if you have people who are working on neurotrauma, like let's say it's neurotrauma, let's say it's, or, whatever you want to make it. Let's say, we'll go with neurotrauma. 5 different groups can be working on neurotrauma. And it's beautiful that you have those colleagues, but 2 colleagues cannot be working on the exact same topic because they'll steal from each other, essentially. So you have to define your niche specific enough to stay in your own area, if that makes sense. And that's hard to do. And then don't be afraid to change. Like if something doesn't work, kill it, like move on, okay? How do you recreate a niche? So a great way to create a niche, and these are very inexpensive ways to create a niche. Repurpose a drug, okay? And we do this all the time. So there's something that we use for seizure, and maybe we think it's a neuroprotectant. Try it in trauma, okay? And vice versa. We do this all the time with drugs. So just be on the lookout for how can a drug be used in a different way. And if nobody has described that, you should be the one that describes that. Figure out an easier and better way to diagnose a patient. This is huge, okay? So how do you diagnose an epidural hematoma? You use a CT scan. Is there a way to do that that's easier or better? Well, you can use an MRI scanner, but that's more expensive. I mean, it's less radiation, but it's more expensive. So could you create something where you had a less expensive MRI scanner? I don't know. Could you create a way of diagnosing an epidural hematoma that didn't involve a CT scanner? People are working on that. Determine whether something is necessary, okay? So let's say you're treating high blood pressure. Is the drug necessary? Is there a way to get around using whatever drug that you're talking about? Can we do it faster, cheaper, and safer? This is huge, and this will be really big in the upcoming years. And take a step back and see what's working and what's not working. And we'll talk about that in a second. So a lot of times protocols will let you know whether something is working or not, because you keep doing it the same way every time, and then you can kind of compare what's working and what's not. And it really is a return to first principles. So, and Race, you heard this story. This is one of my favorite American presidents, actually my favorite American president, Abraham Lincoln. Amazing, amazing man. Unfortunately, at the end of his presidency, he was shot in the back of the head. He was shot in the left occipital. They think that the bullet probably went ipsilateral and ended up just above his left eyeball. If President Lincoln was just a normal American male, and he presented to any major neuro or trauma center, he would have an approximately 50% chance of mortality, and he would have about a 25% chance of a good outcome. And why? Because we know that he was above the age of 35. I am too. We all age. And when he presented, his GCS was 3 or 4. He really wasn't doing much. But he probably would have gotten, at my institution, I would have given him a hemicraniectomy, seen if I could evacuate the hematoma that was there, and then try and get the bullet if I could. If I couldn't, I wouldn't. But I would probably leave the bone flap off and put him in the ICU and let him heal. So, back in the 19th century, President Lincoln actually survived without all that fancy equipment for several hours. And how did they do that? They sort of stuck their finger in his bullet wound and evacuated blood manually. Okay, but he was still able to breathe. So what's the difference? Why are we doing so much better now? Well, we have better drugs for emergency medicine and resuscitation. We have blood products, and we have coagulation replacement. So President Lincoln probably had a coagulopathy from release of tissue factor. Plastics is huge in medicine. I mean, game changer in terms of ET tubes, catheters, Foley catheters, IV catheters, things like that. Advances in surgical technique and anesthesia. In the 19th century, surgery was way more fraught with mortality than it is now. Antibiotics and hygiene, just basic hygiene, is huge. And then evidence-based medicine. Our ability to communicate our results with each other in an open fashion, which I'm hoping continues as time goes on, and our ability to take from each other and see what works and what really doesn't work. And enhanced communication. So that's a game changer right now, is our ability to share our results with each other. And I think within my lifetime, we're going to come up with some other way than journals to share this information. I think I think journals are going to go the way of like books and lectures, honestly. And I'm waiting to see what that method is. And maybe one of you, that's one of the 28, 30 medical students out there, is going to be the one who creates this communication thing that I can't quite wrap my mind around, but is going to produce information in a faster, more efficient, and more easily shareable way than journal articles, which, I mean, let's be honest, aren't very efficient. Guidelines and protocols, and the ability to share these things. Like, if you can make it work at your hospital better than the way I make it work at my hospital, I want to know about that, and I want to use it at my hospital because I want to give my patients the very best treatment possible. So I've talked a lot about the struggle that we have to do research, but okay, so what are the solutions? I mean, that's what you ought to be asking me. Like, you talked a lot about the struggle, but how do we make research better? So common data elements. And what this essentially is reporting our research using the same language. So everybody agrees, okay, this is the best way to describe this disease process, and we're all going to describe it using these methods. And we're all going to report the same thing. And this seems like a no-brainer, but people aren't doing it. So you'll read, for me, subdural hematoma, and how do patients do after that? But some people report whether they get an infection or not. Some people report, their outcome in terms of their neurological outcome. Some people don't. Some people report the mortality. Most people report the mortality. I mean, that's pretty basic. But it's these different ways of reporting that make meta-analysis so hard. Okay, so if everybody reports it the same way, your meta-analysis is much easier, and you can combine the research and come up with better results. Multidisciplinary research. You should get friends, okay? And you should get friends that do things that are different than what you do. And the reason why is because as we share our research with colleagues who are doing slightly different things, it enriches our research. You should get friends in different places. In your institution, there tends to be one way of doing something. And when you go to other institutions, they're looking at it slightly differently. And maybe they're doing it worse. Maybe they're doing it better. They're definitely doing it differently. If you can do this internationally, that's even better. Protocol-driven care. I'm going to say the word protocol probably 50 times in this lecture. I absolutely believe in protocols because if you're not doing something the same way every time, you can't study what you're doing because you introduce too many variables. And you understand what I mean when I say protocols, correct? Cool. Okay. Any questions out there, please let me know. Organizational assistance, letting your, joining organizations and, using those organizations, using those relationships to help you with your research. In terms of writing your first manuscript, how many people have written a manuscript? Raise of hands. Raise your hand if you've written a manuscript. Okay, okay. All of you should be doing this, okay? All of you should, and don't worry about screwing it up, okay? You don't have to submit everything that you write, okay? So but you should try. You should try. First of all, mentorship. I cannot emphasize this enough. You have to find somebody that's done it before you that can help you guide through it. And the reason why, what I always tell the residents is that none of them have to make a mistake, because I've made all the mistakes and I can tell them how to avoid the mistakes. And you want somebody who can help you avoid the mistakes. When you're writing a manuscript, what I want you to do first is I want you to look at your data. I want you to create your figures. And from those, the way that I go through a manuscript, and you can do it differently than I do it, that's fine, is I look at my data, I create figures. Once I have anywhere from like 4 to 6 figures, I'm like, okay, that's a paper. I have a story to tell. And then I write my results. Once I've written my results, I need to tell people how I did what I did. That's my methods. Who cares? Why did we do this research? That's your introduction. And then what's next? Who cares what's next really is your discussion. And so you see, like, each part of these papers, like, you'll read these papers and go, oh my God, I can't believe, how did they write this up? This is how they wrote it up. It's not hard. You can do this, and you should be doing this. And then this is a big one that everybody misses. And as an editor and as somebody that reads a lot of papers, I will absolutely send your paper back to you if you don't tell me what the limitations are of your research and if you're not honest, okay? Pitfalls manuscripts. Edit that paper over and over again. And what I generally will be doing when I'm like, everybody in my lab knows when I'm editing a manuscript, because I will literally walk out of my office and I'll be pacing the hallways while reading my manuscript, okay? And I'll have a pen with me, and I'll bump into stuff because I'm looking at this paper and I'm like, walking into stuff. But I mean, like, and I'm just walking the halls, editing this manuscript, reading this manuscript over and over again. And at some point, you've read it so many times that, like, you're missing things, and that is when you hand it over to other people and have them read your manuscript. And it ought to be people who are in your research, and it should definitely be people that are outside of your research. Check your grammar, check your spelling. Nobody who reads the people who read your paper are not getting paid to read your paper, and they don't want to see spelling errors and grammar errors. And then know your audience and know your journal, and we'll talk about that in a second. Use of AI. ChatGPT, there are a couple of different ones, Gemini. These are tools. Don't use AI to write a paper, but definitely use AI in research, like researching your paper, and check the AI, make sure it's not giving you something funny. And you can even use AI to sort of give you a rough idea of how to write something, but write it in your own language, okay? So it's totally fine to use AI, but you have to use it wisely. When you're going to send out a paper, it's sometimes hard to figure out where to send the paper. This website, so jane.biosemantics.org, is beautiful, and it's free, okay? So what you literally do is you go to this website, you type in the title of your paper. So let's say it's, I'm obsessed with coffee, one of the reasons why I love Indonesia. And let's say I'm writing a paper on caffeine and its role in improving outcome in traumatic brain injury. So I would type that in, and then it would give me all of these different journals. So I could send my manuscript to Journal of Neurotrauma, Experimental Neurology, Brain Sciences. It's just an easy way to find out. So when doing retrospective research, always remember this. This is a huge pitfall that I see people fall in all the time. In the United States, we have this myth that storks bring babies. Stork is like a bird that we have. And the myth is that the storks bring the babies. And if you look at human populations actually follow the number of storks that you have in one area. So if you're very unwise, if you're a very foolish person, you could say that this proves causality, that storks actually bring babies. We all know that's not true. So what is this? It's correlation, not causation. How do we explain it? Storks don't bring babies. But stork populations correspond with land area, and land area does correspond with birth rate. Okay, the more area people have, the more kids they have. Makes sense from a biological standpoint. So what I mean when I say this is, in your retrospective research, you may think that you have something that shows X causes Y. But if you're looking at it retrospectively, you cannot say that. And if I get your paper and you say that X causes Y rather than X is correlated with Y, I will send your paper back to you. So do not do that, okay? How do you prove causality? So causality is actually really hard to prove. In infectious disease, if you want to say that a disease or an agent causes a disease, you have to have an organism that is healthy, right? Doesn't have your bacteria. Then you take a diseased organism, you isolate that bacteria, you inject that bacteria into an animal that is healthy, and then you reproduce that infection. That's huge. Like that's how you prove causality, okay? So causality is a big, like that's way up here. Correlation is way down here. This is what I mean when I say protocols. So just standardizing care, okay? This is huge for research, and it's huge for patient care. It's huge for patient care because it means that patients get treated the same way. And what you can do if you have a protocol, and if you have a disease process that you love, it could be kidney disease, it could be heart disease, it could be liver damage, create a protocol. Help, and you're all medical students, so you're not going to create the protocol, but find a professor that wants to create a protocol and create a protocol. And then decide how you can change this protocol to optimize patient care. And the research that you can do could be like, what happened before we had the protocol? What happened after we had the protocol? And the protocol may make things worse. If it does, okay, stop using the protocol and report the research, right? But the biggest thing is improving patient care and doing research on it. The current state of our guidelines, and there's a huge, the reason why I sort of am harping on this is because there's a huge opportunity for this. So just in where I do research, we have a third generation of pediatric guidelines for traumatic brain injury. We had no level 1 recommendations, not a single one. So we haven't done very good research. We had 3 level 2 recommendations, and then 15 were level 3. So there's a lot of room for improvement. For our adult guidelines, the last time they were released was 2016. There was 1 level 1 recommendation, 9 level 2 recommendations, and 4 level 3 recommendations. So the other thing is, if you're thinking about going into pediatrics, and God bless you, I think you absolutely should. We need good people in pediatrics, but we are doing worse than our adult colleagues, and we need to do better, okay? So what I want to leave you with is I want you to know the guidelines, find that thing that you just love, that just moves you, and read up on the guidelines, really know those guidelines, and then try and improve them. My goal in life is, I mean, literally, this is one of my goals in life, is to get my guidelines before I stop being a doctor, okay? Haven't done it yet, but I'm still working on it. Really, where, after you've read the guidelines, the place where you really want to go is the future directions, because this is where it tells you where the research really is, okay? So, and you can find out, like, what are the unanswered questions. And the good news is, for us in medicine, is that over time, we're doing better. So in my own practice of traumatic brain injury, if you look over time, mortality rates are falling. And a lot of it is because we're just taking better care of our patients and using research to improve our care. In my own personal experience, we had a protocol that we instituted at Emory University Hospital in Atlanta. And before we had this protocol, we were allowing the intracranial, the brain pressures to get really high in these traumatic brain injury patients. And because of that, our mortality was elevated. We introduced a guideline, and after we introduced that guideline, our intracranial pressures were dropping, and so were our mortality rates. And so again, I can't emphasize this enough. Protocols are like Copico, okay? It's a twofer. Copico is a delicious candy that I found and loved when I was in Indonesia, and it's also a great source of caffeine, okay? So it's like a twofer. Protocols will both improve your patient care, and they can be something that you can use for your research career. And so how do you do this in your busy clinical practice? So first of all, establish a guideline. Just establish something. Optimize those guidelines. Make sure that those guidelines are working. Make sure you're doing a better job after the guideline than you were doing before. Cultivate relationships. So that guideline that I talked about was at least 4 or 5 different hospital entities. So critical care, emergency medicine, neurosurgery, surgery, not nursing, okay? So a lot of people had influence on this. And then establish a collaborative research environment. And for my own practice as a pediatric neurosurgeon, I mean, of our practice guidelines at my hospital, 2 of them I wrote myself. One of them I had a very strong influence on, and then the other 2 I helped edit. So of those, what is that, like 6 guidelines, the only one that I didn't work on was solid organ injuries. And I mean, like that pediatric neurosurgeon doesn't need to be on that one, okay? But everything else I had a hand in. And in terms of networking and organizing, and I'm going to give you a lot of different organizations. So for my own personal networking and organizations, I use my hospital. This is my hospital. I use my region, okay? So most of you are probably in Jakarta. I guarantee that somewhere in Jakarta, for every disease process you have, there's an organization of doctors that are working on that disease. You need to find that organization and then become a part of it, okay? There are national organizations. So these are some of them that I belong to. The pediatric neurosurgery. This is an injury prevention organization that I belong to, and this is a trauma organization that I belong to. Had I not gone to ICRAN this year in Surabaya, ISPN, I'm going to in Lyon, France next week, actually. And then World Neurosurgery is a beautiful journal for this, okay? So find these organizations. For those of you who are interested in neurosurgery, especially pediatric neurosurgery, ISPN actually has a fellowship, a traveling fellowship. And I would invite you to apply for this. And you can use me as a reference, and you can come and visit us in Columbus, Ohio. And this is a great opportunity if you know, and it doesn't matter. Like if you have an interest in kidneys, okay, find the International Kidney Organization, find a traveling fellowship for the kidney organization, and then write me, okay? My last name is Sribnick. I'm not hard to find, okay? I'll hook you up with one of the nephrologists at in Nationwide Children's Hospital. We have some really good ones, okay? As far as workshopping research, patience. And this is all things that I am, even as a 49-year-old, I'm working on. I'm definitely working on patience. You can ask any of my family members. Listening. I'm working on listening. It's constant humility. I'm definitely working on humility. Honesty, I think I've got. Of all these 4, like that's the only one I have a hand on. Idea generation is a beautiful, like that's really where it is. You want to have a good idea. You want to come up with a good research proposal, data analysis, writing, and then peer review. My final thoughts for this is the big one. Don't ever give up, okay? Vocation, avocation, and family. These are all very vocation, avocation. So a vocation is your job, an avocation is your hobby, and then your family is your family. You can have 2 of these and do it well. You can't do 3 well, so you have to choose. For me, I've chosen my vocation, my job, and my family. And I don't really like if I'm going to do something for fun, I'm going to incorporate my family into it. Okay, but I'm not like going out and golfing for 8 hours because then I would be ignoring my family. Take 10 minutes to 1 hour every day for yourself, every day, even as a medical student. And this can be prayer, this can be working out, this can be watching a TV show, this can be talking to your mom. Oh my goodness, you have to do this because life needs a little bit of fun in it. If you're going to fail at something, fail fast. Okay, don't linger on something. Let it go quickly. You know, figure out, do an experiment where you decide whether it works or it doesn't work, and if it doesn't work, let it go. Love what you do, and if you don't love what you do, figure out why you don't love what you do, and then change it. Okay, because we're all too busy and we're all working too hard to not love what we do. Any questions for me? These are all the different methods that you can use to find me. A lot of different ways to contact me. I went way over time, didn't I? Sorry about that. Any questions?
I think from Ibrahim, he wants to ask something, Professor.
Please.
Okay, thank you so much, Ines, and thank you so much, Professor Eric, for the amazing presentation about research. Beforehand, I'd like to apologize that I unfortunately cannot turn on my camera as of now. But for my first question, I guess it's quite basic because I'm just looking this from the point of view of medical students, and most of medical students in Indonesia, we are still in our preclinical years, which means that we are not used to seeing actual clinical interventions, and we're not used to seeing patients and real life medical scenarios in our life. We're just still going on lectures and practicals. And in regards of research, we're also very limited because it's quite difficult for us as medical students in Indonesia to actually find fundings and experience in primary and laboratory research. And the most that we can do, and what my friends and a lot of people in medical schools in Indonesia do, is just systematic reviews and meta-analysis, or just secondary research. Do you still think that it's possible for us, maybe in like doing secondary research, is it still possible for us to do an actual robust research to actually influence clinical practice and guidelines that are done by doctors in like medical settings? Or do we really have to maybe expand and broaden our connections to find maybe doctors or professor that is enrolled in organizations or collegiums that is focused on working about a certain issue in medical field to help push our research paper and results to actually influence those clinical and practice guidelines? Thank you so much.
Yeah, I think it's there are a lot of ways to do that. So probably the simplest way to do that is first to make a connection with someone. Okay, so from one of the first research projects that I did, you remember that guy that I told you about, Dr. Patel? What I did was I met with Dr. Patel. He got to know me and he said, "Hey, why don't you come and see me in the operating room?" Okay, so it wasn't even about the research. And that's the thing, is that connections come first, and then research comes from those connections. So as a student, I'm meeting with him. He's going to the operating room, and I'm going to the operating room. And for me, every time he went to the operating room, I was in that operating room, okay, for like a couple weeks. And I saw a bunch of surgeries, and I saw what he did. And just very naturally, he would say, "Hey, I'm working on this thing. Would you like to work on it?" Okay. As a student, if you can get funding, that's beautiful. Like, you're way better than I was. Okay. Because I never had funding as a student. Right. But what I did have was I had connections with these professors and doctors, and they would let me in on their research. So they were doing research, they had funding, I would tag along, and I would get my name on the paper. And I wouldn't be the first author, right? But you work your way up to that. And as you do more research, you become a greater expert on one thing. And then that's when you can start securing funding. And by that point, you're not even a student anymore, but you've already gotten your name on several papers. And so it really is about, you don't have to hit, here, this is going to be a metaphor for baseball. You don't have to hit the ball out of the park and, like score a run every time. It's a matter of just getting in there and doing it again and again. And eventually something will take off. Okay. Does that make sense?
Yes, yes. So I'd like to summarize. That means that we really do have to, I guess, what you mentioned before is that take a lot of things, but not everything, and maybe try to find a lot of opportunities to tag along in research and make your way up from there. I actually have a follow-up question for this one, because you did mention that you were focusing on a certain field of research and that you got used to it, right? For medical students, like this is our first steps on doing research, right? Do you think it's better for us to actually find one singular or particular field that we have a lot of interest in doing research and actually doing clinical practice on it, and like work our way up to, so we can get more used to that field? Or do we should just expand and do research in a lot of fields and just find out what works out for you, even though you don't really get used, and work your way from there?
I think both can be done. I think for me, when I was doing research, everybody knew that I wanted to do neurosurgery. So when I was on pediatrics, we had a patient with moyamoya disease. And immediately everybody said, oh, hey, Sribnick, why don't you write that one up? Okay. And so that was like, a clinical, I did a little clinical paper on that. That was actually the first thing I ever published, was a clinical study on the youngest African-American female to ever have moyamoya disease. But that was in pediatrics, right? But they knew that I wanted to do neurosurgery. And so I was able to get one of my neurosurgery colleagues to come in with my pediatric colleague, and we wrote that up. But I think the biggest thing is finding a mentorship, like finding people who are willing to take you on as a student and guide you through not guide you through the process, but at least help you through the process.
Okay, thank you so much, Professor, for the answer. I guess I can continue on with the next person who wants to give the questions.
Yeah.
Okay, from the chat, from the meeting chat, there are two questions. The first one is from Dina. Maybe you can read, Professor, in the chat.
Oh, yeah, of course.
She wants to ask about how do you maintain consistency in publishing your research, and how do you find or build the right environment and resource to start a meaningful research project?
Yeah, so part of that is you always want to be completing your project now. So you also always want to have like several other things that you're working on at the same time. And so I have a folder that has active manuscripts that, are in whatever stage of publication. And then I have partner manuscripts that I'm working on with other people. And, once a week, every week, I'll call these people and I'll say, hey, you gotten any work done on, X, Y, or Z? And it really allows you to kind of have a consistent publication record. And that's different for everybody. I mean, for me, I try and put out 5 to 6 publications per year consistently. Sometimes I'm a little bit above that. Sometimes I'm a little bit below that. It's the metaphor that I would use for research and clinical medicine is you've got to keep all of the plates spinning. Do you know what I mean when I say that? Like there's at carnivals, we'll have these they'll have people with these sticks and they'll spin plates on them. And the key to it is you got to keep spinning these plates. And so you have to be focusing on several different areas. And it can be hard, but it really is a matter of, again, cultivating relationships, making sure that you have good colleagues that are all working with you, and keeping each of those fires, those little fires that you have going, lit. So, you put a little bit of kindling in each one at each time. And as you finish projects, other projects will come up. And then there's Fikri thank you, Professor. I have a question. How can translational research integrate systematic patient outcome monitoring to demonstrate and improve treatment efficiency? That's an amazing question. That's a really good question. So part of that is I want you to, I think that question is, how do I show that I'm doing more with less? Is that the question? Fikri, are you there?
I think that is the question, Professor.
So the way that you show how am I doing more with less, essentially, is you figure out how much it costs. It's as simple as that. So, and the cost can be how many hospital days, how many hours in the operating room, how many dollars or, am I spending on doing this research? So you look at a currency, and that's, you have to have an outcome for your translational research. And those are easy ones to use. Hospital days, ICU days, dollars spent, time spent, things like that. Other questions for me?
I think from Mikkel. He wants to ask something.
Okay.
Oh, yeah, please.
Is my voice clear?
Yes.
Okay, first of all, thank you very much, Professor, for the excellent presentation. I have one question, actually. Since Indonesia is a very diverse country with diverse cultures, how can socioeconomics, cultural, and also policy factors influence the implementations and also outcomes of translational research initiatives in clinical practice? And how can we maximize that impact?
That's a great question, and I totally agree. First of all, Indonesia is huge, and it's got a diverse population with diverse demographics. The other thing is you have a ton of islands, right? It reminds me a lot of the United States in terms of just the beauty, in terms of the demographics and the diverse cultures. You have to incorporate that in your research. Low-hanging fruit on something like that would be, you've got part of the population. If I was going to study that population, you have part of the population that smokes, you have part of the population that doesn't, you have part of the population that drinks, you have part of the population that doesn't. You have different sectors of the population in terms of access to healthcare. So if you live in the center of Jakarta, you're going to have an easier time of getting to the hospital than if you live on a remote island. So how does that impact your care? That's low-hanging fruit for you guys. Would be my guess. Given what I know about the country. Does that answer your question?
Yes, thank you very much for the.
Yeah. And then there's another question here. Somebody who can't turn on the microphone. You once said that we need to move on when something doesn't fit us, but how long should we keep trying before deciding whether to move forward or stop? How can we truly tell if we want to pursue and dedicate ourselves to our field of expertise, especially when we haven't learned much about it yet? That is a really profound, very deep question that I am unfortunately going to give you a terrible answer for. You're going to pick what you want to do with your life without actually knowing how it's going to turn out. And that's going to happen several times in your life. And I'm so sorry to say it, but so the major decisions that I made in my life that I had no information for were my career, picking a house. Like, you're going to buy a house and you're not going to know whether the house is good or bad. Okay. Getting married, you're going to get married, maybe, maybe not. And you're not going to know whether, like, what that's going to look like until you're already in it. Having children, like, you don't know what it's like to have children until you already have children. And by that point, it's too late. So the best you can do for choosing these things is to try and find as much information about them as you can and try them on for size. But unfortunately, a lot of it is a leap of faith. And what I will say to you is this, is that even after you've made the choice, you can tailor the choice to fit you. So when I went into medical school, I thought I was going to be a surgeon. I thought I was going to be a general trauma surgeon. And then I decided I wanted to do neurosurgery, but I made it neurotrauma. So I sort of melded those two together. And then at some point during my neurosurgery training, I realized I didn't like adults and I liked treating children. And so I decided on pediatric neurosurgery. And if you told me when I was a college student that I was going to be a pediatric neurosurgeon, I would have absolutely told you you were out of your mind, because I didn't think that, there's no way I would have thought that. So it's part of the journey. The biggest thing that I can tell you is just try and learn as much as you can about it before you make the commitment. But you're going to make the commitment without all the information. That's for sure. Unfortunately. Other questions from me?
Okay, I think for the last question from Alia. Yeah.
Okay, thank you very much for the opportunity. I'd like to ask in the context of participating in a research, maybe developing clinical guidelines, in your personal opinion, is it more needed to do research about currently existing dilemmas of existing guidelines, or finding completely new interventions or treatment options that are novel?
The beauty is you can do both, or you can do either. And I think they'll have similar impacts. The great thing about if a guideline doesn't exist, I wouldn't choose it by the guideline, I would choose it by the disease process. So Aaliyah, what are you interested in?
I'm still very open to all fields. I feel like I'm not specialized yet. My interests.
Okay, give me something that you like doing. Give me an organ system. Kidneys, liver, heart, brain.
Let's say heart.
Heart. Okay, beautiful. Okay, so let's say like congestive heart failure. If a protocol exists for that, then you wouldn't need to invent one. You would optimize that protocol. But if you have something like, let's go with for heart and congestive heart failure, there probably is a protocol, right? I mean, like that's a huge, but let's say something that's really, really niche. So subarachnoid hemorrhage causing Takotsubo heart disease. Okay, does everybody know what Takotsubo heart disease is? It's a very specific congestive heart failure where the ventricle, it's actually a Japanese, Takotsubo is a Japanese word for like these these containers that they use to catch squid. And what happens if you have a subarachnoid hemorrhage is you get a lot of blood in your head, and then on your echocardiogram, you can see that you have the ventricle thins out, it becomes very thin, and then your ejection fraction goes way down, and you can't pump enough blood. So, you, Aaliyah, could go to the neurosurgeons and the neurocritical care unit and say, do you have a protocol on Takotsubo heart disease for patients with subarachnoid hemorrhage? And they would say, oh, no, we don't, but would you like to write one? And then what you would do if they hadn't already written one is maybe you would look at the different ways that they treat this. And you would find all of the commonalities that they use, but maybe you would see that some people use epinephrine, some people use dobutamine, some people use norepinephrine. What are the differences in those? And does it look like some patients do better with one or the other? And so now you have a study. You can say, okay, in patients with subarachnoid hemorrhage grade 3 who have Takotsubo heart disease, is it better to use dobutamine or epinephrine? And that right there is research. And once you've decided, okay, I think dobutamine is better. So then you look at what happens when you switch to dobutamine, okay? And now you've suddenly got a research paper. And that you could do with very little funding, okay? Because they're already in the hospital, you're already going to treat them, you're just shifting the practice very slightly, and you're seeing what the outcome is.
Okay, thank you very much, Professor. So it very much depends on my area of interest and maybe the specific disease. If it's very niche, then maybe I can try to find new outlets of treating them. But if it's a kind of general or regularly occurring disease, especially here, the chances of there being an existing guideline are higher. And in that case, maybe we do need to help solving dilemmas in clinical guidelines, in existing clinical guidelines.
I could not have phrased that better.
Okay. Thank you very much.
So that is the last question from Alia. I think I want to conclude the whole presentation from Professor Eric that that we have seen tonight. So what I learned is that you highlight that we cannot we should not be giving up, and we have to keep trying, and then be specific, find your niche topic for a specific field if you want to do a research. And then Professor also discussed about the struggle and then the solutions in doing research, and also the tips for networking and organizing in doing research. Okay, I think for now, because we already have the question and answer section, we can do the post test. For Fikri, can you give the link? Okay. For all of the participants, you may fill the post test link in the chat. And for Professor Eric, can we take a picture for the documentation?
Oh, of course. And I just want to say thank you so much for inviting me. And I think that you guys already know what you need to know about research. And the reason why I say that is because in your background, I'm seeing in the bottom right, research is fun. I could not agree more. That's how it has to be. Love what you do, make it a game. That's how it is. Thank you.
I also agree with that research is really fun. Okay. While waiting for the participants to fill out the post test, I would like to give the certificate for Professor Eric. Wait. Okay, so we have like a certificate for you.
Oh, thank you.
And we can take a picture together for Joy. Joyce, maybe you can, yeah, can you help us?
Okay, wait.
Do you want me to stop sharing?
Oh, no. I think, oh yeah. I think the screen now is it's from my screen, Professor. So it's,
Okay,
yeah.
cool. Oh, perfect. Oh, thank you so much.
Okay, so we're gonna take like 2 pictures. The first one is we can do like smile, and then the second one you can do this sign. Can you do this? Yeah. So the first one we can do the smile first. Okay, Joy, you can say it when you're ready.
All right. For the first one, we can smile. I'll count to 3 and you guys can smile. All right. 3, 2, 1, smile. Wait. All right. All right, for the second one, you guys can do this. Yeah. All right, I'll count to 3. In 3, 2, 1. All right, I'm done.
Okay. Once again, thank you so much, Professor, for joining us tonight and giving us so many knowledge and insights. For me and also for the other participants, it's a really interesting topics, and if maybe if the other participants want to ask more, there is the contact number and the email for the professor. If you guys want to ask for it, I will share it to the group later. Okay, so thank you. If you have any other things to do, Professor, you can you may leave.
Yes. Okay, thank you guys. Bye-bye.
Thank you.
Thank you, Professor.
Thank you.
Untuk teman-teman yang lain juga boleh diselesaikan untuk prosesnya. Fikri, apakah ada dokumentasi lagi atau apakah ada dokumentasi lagi?
Aksesnya udah cukup, sama aku mau ngucapin terima kasih banyak pada partisipan yang udah hadir setia sampai malam ini, yang sudah stay di Zoom, yang udah dengerin dari Profesor. Aku ucapin terima kasih banyak teman-teman. Semoga ilmu yang disampaikan oleh Profesor Eric bisa didapatkan dengan baik ya teman-teman semua. Insight jujur ini keren banget ilmunya. Oke, thank you so much guys. Semoga malam mingguannya bisa dilanjutkan lagi ya guys, kalau misalnya punya kesibukan masing-masing. Have a nice great day guys. Oke, dan tahu teman yang ada kesibukan tersendiri. Makasih guys yang udah join.
Terima kasih teman-teman
Thank you
dan
guys.
kakak-kakak semua.
See you in another opportunity.
Untuk PPT-nya mungkin bisa di-share ya Fikri nanti di grup atau ya.
Oke, ya. Nanti juga dari code-nya stay tune di YouTube-nya Cari Cinta guys.